CSEP and NISOS, under our presidents Jim Martone in Connecticut and Peter Menger in New York, feel strongly that our ophthalmic technicians are important contributors to our team. And we've directed the efforts of our combined societies to include this virtual education program during the strenuous times of the COVID-19 pandemic. CSEP and NISOS would like to thank you for going to work every day and showing the dedication and endurance that's needed to succeed. We know that many of you show up to work and risk your own health in the delivery of care to other people. Through the diligence of our executive directors, Deb Osborne in Connecticut and Robin Pellegrino in New York, we welcome you to this afternoon educational program designed for you. I'd like to take a moment to recognize our sponsor, Regeneron, for their generous support for this program. Regeneron, they push the bounds of science, making life-changing medicines, and we're all very familiar with their products in our everyday work. Our meeting today will end at 5:30 with more door prizes, and we hope that you will win and enjoy them. It's my pleasure now to welcome our first speaker, who's Scott Walter. He's been a very influential force in Central Connecticut since he started practice several years ago. We're very lucky to have him here in Connecticut. He did his fellowship in retina at Duke University Eye Center and an ocular oncology fellowship at Bascom Palmer. He's currently Vice Chief of Ophthalmology at Hartford Healthcare. He's Assistant Director of Ophthalmology at Hartford Hospital. And he has offices in Hartford, Cromwell, and Farmington. So he's a busy, busy guy. He's going to talk to us about the rising prevalence of diabetic retinopathy in the United States. And he's going to review the stages of diabetic retinopathy and some of the treatments that we have at our fingertips for them in his talk titled Diabetic Retinopathy, Preventing the Next Global Epidemic of Blindness. Welcome, Scott.
Thanks, Ed, and thank you all for joining us this afternoon for some education. It's nice to be back together, and sorry we're not doing this in person yet, but I want to echo what Ed said about how grateful we are to all of our staff for the hard work you've put in over the last 2 years during the pandemic. So I'm going to try to share my screen here, but I need the host to allow that so we can bring up my slides. We know how to allow screen sharing. There we go. All right. Share this. We're going to go back to the beginning here. All right, so here we are. So again, thanks for joining us. This is the virtual program for CSEP, as Ed told us. I'm Scott Walter with Retina Consultants, and today we're going to talk to you guys a little bit more about diabetic retinopathy. So let's dive in, and we'll start by talking about what is diabetes. Diabetes is a disorder of glucose homeostasis, which leads to chronic hyperglycemia or elevation of blood sugar levels. So first of all, what's a normal blood sugar level? If you're fasting in the morning, it should be less than 100. If it's in that 100 to 125 range, we refer to that as prediabetes. And if it's anywhere above 125, we consider that diabetes. As it gets critically elevated above 250, we see some other metabolic changes that occur, such as ketoacidosis, which can lead to altered mental status. And at very high levels, over 400, the urine is actually excreted in the urine. And so that's where the name diabetes mellitus comes from. That's actually Latin for peeing honey, basically. So if your blood sugar was uncontrolled back in ancient times, eventually you'd just be peeing very sweet urine. And so that's where the name originated. So there's two forms of diabetes. There's type 1 diabetes, which is a relatively rare form of diabetes. It's an autoimmune condition. It's often seen in children and young adults. And basically, the immune system attacks the pancreas and causes damage such that the pancreas is no longer producing enough insulin. And insulin is a hormone that tells your body to store sugar in muscle, in fat, in the liver. And if you're not storing the sugar in those organs, that leads to high blood sugar in the setting of low insulin in type 1 diabetes. Type 2 diabetes, which is common and only becoming more common, is a metabolic condition that's often seen in overweight and obese adults. What happens in type 2 diabetes is a little bit different. So instead of damage to the pancreas, the patients are developing resistance to insulin in the peripheral tissues, in the muscle, in the fat, in the liver. And this leads to high blood sugar in the setting of high insulin levels. So your body is producing insulin, but it's not able to respond appropriately to that insulin. And so you're not storing the glucose like you should. So this is called insulin resistance. And we've kind of referred to insulin resistance initially as pre-diabetes. So as I was saying, when you eat food, your body produces insulin, which tells the muscle, liver, and brain to store glucose. But as you develop insulin resistance, the sugars are not stored in those organs, and they get stored in fat. And that leads to a feeling of tiredness and hunger that leads you to eat more food. And it becomes a bit of a vicious cycle where the sugar is not getting distributed to the appropriate organs, and you're feeling more exhausted and hungrier, and it just is this vicious cycle that feeds into itself. So can we break the cycle? Yes. Diet and exercise can kind of cure pre-diabetes. So some of the things that patients can do early on in the course of the disease is to eat foods with a lower glycemic index. So things like raw vegetables and more complex carbohydrates like rice, whole wheat, legumes, and avoid foods with a higher glycemic index, like this stack of pancakes here with syrup and sweet berries on top. And also things like sugar-containing sodas certainly have a very high glycemic index. The other thing we can do early on is to exercise more. So exercise actually increases the glucose sensitivity of muscle and overcomes some of that insulin resistance. So you can see here on the graph on the right that after exercising, the muscle is actually more sensitive to the effects of insulin. So if we don't break the cycle of insulin resistance, what ends up happening? Basically, eventually the pancreas kind of burns out and runs out of insulin, and you become an insulin-dependent type 2 diabetic. So you need to take insulin in the form of a drug that's injected. This is just kind of showing us what happens. The patient still has insulin resistance, so higher and higher levels of insulin are required to manage the blood sugar as the pancreas kind of loses the ability to produce insulin on its own. So let's shift gears a little bit and talk about disease management, and we'll touch on some of the systemic management, and then we'll really drill deeper into the ophthalmic management of diabetes. So there's a whole slew of medications here which are used to treat diabetes. The one I want everyone to recognize is metformin. Metformin is the most commonly prescribed anti-diabetic medication. It has a lot of beneficial effects as far as decreasing weight, decreasing people's appetite. It actually works by decreasing glucose production in the liver and improving the liver's insulin sensitivity so that it is better at storing the glucose instead of releasing it into the bloodstream. So this is kind of our first line agent for many patients with diabetes. And then as far as monitoring the disease, hemoglobin A1C is an important measure of blood sugar control that we should all know about. So it's an indicator of the average blood glucose levels over the past 2 to 3 months. And ordinarily it's being monitored about 4 times a year, every 3 months or so by the patient's primary care doctor. So a tip here for the text, it's a CMS requirement that the patient's A1C level be documented at every visit. So if you're working up a patient, you can really help the doctors out by asking about their A1C and making sure that that's included in the documentation. Okay, so the normal range for an A1C is anywhere from 4 to 6. As we get into the 6 to 7 range, that's considered well-controlled diabetes. So if your patient tells you their A1C is around 7 or below, you should be telling them, give them some positive feedback. You're doing a great job controlling your blood sugar. If we get to higher levels in the 7 to 8.5 range, that's kind of borderline control. So I think it's still a good idea to, reassure the patient that they're doing a pretty good job managing their blood sugar, but it could be lower. And really, you should be aiming for a number closer to 7 if you're in this range. As we get into higher numbers, we're talking about 8.5 to 10.5 here. That's considered uncontrolled diabetes. So if your patient reports this, you should alert the MD to the fact that their A1C was edging up above 8.5, because each point the A1C rises above 8, the risk of vision loss approximately doubles. So we're getting into the danger zone here when those numbers are climbing up into the 8s, 9s, and 10s. As we get to really poorly controlled diabetes, 10.5 and above, then we're really in the danger zone. And so it's important, even if your patient's blood sugar is controlled now, to ask what's the highest your A1C has ever been, because they may have started out with a number up in the 10s, or above. And most patients whose A1C has ever been greater than 10.5 will eventually develop some degree of vision-threatening diabetic retinopathy. So it's important to have that historic data on record, as well as their current A1C level. So let's talk about, shift gears again and talk more about diabetic retinopathy, how the diabetes actually affects the retina. So you may have heard of this distinction between non-proliferative and proliferative diabetic retinopathy, and it's really a spectrum, as I've illustrated here. Some of the hallmarks of non-proliferative diabetic retinopathy are vascular changes like microaneurysms in the retina, hemorrhages, which are commonly seen in patients with non-proliferative diabetic retinopathy, and some subtle vascular changes like venous beading or intraretinal microvascular abnormalities. So all patients with diabetes are encouraged and really required to get a dilated fundus exam once per year to screen for diabetic retinopathy. And each year, the physician, the ophthalmologist who's seeing the patient should be sending a letter to the patient's primary care provider specifying the stage of diabetic retinopathy. So if you're responsible for sending those letters, just go ahead and be proactive and send a letter at least once a year or more often if you're in doubt, so that they have those letters on file, because that's actually a critical quality metric that the primary care providers are being graded on. So why do we care about the staging of non-proliferative diabetic retinopathy? Basically, the stage of NPDR corresponds to the risk of developing PDR, or proliferative diabetic retinopathy. And as you can see here, that risk increases pretty significantly when we get into the moderate and severe range of non-proliferative diabetic retinopathy. So these are the 1-year risk of conversion from NPDR to PDR. So any patient with moderate to severe non-proliferative diabetic retinopathy should really be promptly referred to a retina specialist at this stage. So here's some representative images. This is a patient with mild NPDR. They've got a cluster of microaneurysms in the parafoveal region here, and another cluster of hard exudates associated with aneurysms here along the inferotemporal arcade. Moving to severe NPDR, this is defined as greater than 20 dot blot hemorrhages in all 4 quadrants of the retina, venous beading in 2 or more quadrants, or IRMA in 1 or more quadrants. And moderate just kind of falls somewhere in between those two ends of the scale. So now we're going to talk about proliferative diabetic retinopathy. So this is a more serious stage of the diabetic retinopathy, where we're actually seeing the growth of abnormal blood vessels on the optic nerve or elsewhere in the retina. We call that NVD if it's on the optic disc, or NVE if it's elsewhere in the retina. And that can lead to the development of membranes of what we call fibrovascular proliferation or scar tissue on the surface of the retina. And those can tug on the retina and cause a number of complications, which we'll talk about in a moment. So tip for the text, patients with PDR really must be urgently referred to a retina specialist, because once they've reached this stage, things can go downhill very, very quickly. So some of the sight-threatening complications of proliferative diabetic retinopathy include bleeding in the vitreous, which is the gel in front of the retina, or vitreous hemorrhage, traction retinal detachment, where the gel is sort of anchored to those blood vessels and starts to contract and pull away and lead to a retinal detachment, which can lead to severe and potentially permanent vision loss, and neovascular glaucoma, which is where the abnormal blood vessels develop in the front of the eye and actually cause scarring in the trabecular meshwork, which is the drainage system of the eye. And that can cause a very rapid and severe elevation of the patient's intraocular pressure. So this is why once we get to the PDR stage, there's a lot of risk for developing these sight-threatening complications. So in terms of the treatment for PDR, there's treatment with pan-retinal photocoagulation, which is laser treatment. There's injections, particularly anti-VEGF. And then for those complications, there's vitrectomy surgery may be indicated. So here's some images of PDR. This is a patient with very active PDR. Sorry about the sound there. They've got this boat-shaped hemorrhage. They've got some neovascularization and fibrovascular proliferation developing here. And down below, there's some vitreous hemorrhage, which is arisen. So moving to another patient, this patient has evidence of some pan-retinal photocoagulation. You can see these laser scars here in the periphery. They've got some active neovascularization in the temporal macula and some neovascularization on the disc. So let's zoom in on that here. You can see clearly these pretty juicy looking blood vessels. That's the neovascularization elsewhere. And then this area here looks a little bit more regressed to me than neovascularization at the disc. So the PRP is working, but this patient probably needs additional treatment. Moving to the next, fluorescein angiography is a tool that can be used to highlight vascular changes in diabetic retinopathy. So this patient has extensive microaneurysms in the macula and periphery, an enlarged foveal avascular zone, this dark area here, patchy areas of capillary non-perfusion in the periphery, leakage from these multiple areas of neovascularization
It's finally over, that's when we can move them closer. We can cut the tension and
And then just some images here of what we do surgically. So this is a vitrectomy surgery for repair of a traction retinal detachment. I had disabled that. All right, so moving to next slide here. So diabetic macular edema is another vision-threatening complication that can occur at any stage of diabetic retinopathy. So it kind of overlaps here with the spectrum of NPDR and proliferative diabetic retinopathy. This is the most common cause of vision loss from diabetic retinopathy. It's actually the most common cause of vision loss overall in working age adults. So tip for the text here, if a patient has diabetic macular edema, they should also be promptly referred to a retina specialist, even if their diabetic retinopathies are otherwise mild. So some hallmarks of diabetic macular edema is buildup of intraretinal fluid in the retina, hard exudates, which are these yellow spots. Those microaneurysms that we see in all stages of non-proliferative diabetic retinopathy become leaky, and they're actually leaking fluid and proteins and lipids into the retina. So that's what's happening in diabetic macular edema. So here's an example of a patient with severe diabetic macular edema. They're being treated with an Ozurdex implant. So just zooming in here, you can see the microaneurysms, these hard exudates. some cotton wool spots and other vascular changes here. And this is the Ozurdex implant. So treatment of diabetic macular edema includes intravitreal injections with anti-VEGF agents or steroids. Focal or grid laser can be used in certain cases. Here's another video just showing how OCT, or optical coherence tomography, which is a tool we use a lot in the retina practice, it can be used to monitor our response to treatment. So we're going to see here that basically these are some exudates. This is the intraretinal fluid, which shows up as these dark cystic spaces on the OCT. These more hyperreflective foci represent the hard exudates or aneurysms. And then this is a thickness map, which is showing a reduction in thickness as we treat the patient's macular edema. And you can see here on this image that the fluid spaces are reduced with treatment. So some take-home points. In the retina, chronic hyperglycemia from diabetes leads to a number of changes in the blood vessels, weakened blood vessels in NPDR, leaky blood vessels in diabetic macular edema, particularly those microaneurysms, and eventually the growth of abnormal blood vessels, such as neovascularization in proliferative diabetic retinopathy. Again, diabetic macular edema is the leading cause of vision loss from diabetic retinopathy. If a patient with diabetes is complaining of dark spots or strings in their vision, it could be a sign of vitreous hemorrhage, which is a sight-threatening complication that may occur in patients with proliferative diabetic retinopathy and can in many cases cause severe visual impairment if it obscures the view of the patient. It's important to recognize that the incidence of type 2 diabetes is increasing not only here in the United States, but also worldwide. So we do have a bit of an epidemic of diabetes, and with that, diabetic retinopathy following a few years behind. So maintaining a hemoglobin A1C less than 7 really helps these patients reduce the risk of future vision loss from diabetic retinopathy. And again, it's so important to document the patient's hemoglobin A1C level at each office visit. And if the patient doesn't know what their level is, they need a little bit of a talking to about how important that number is so that they're paying attention to it too. Timely referral to a retina specialist can really help prevent the vision loss that can be experienced with diabetic retinopathy. So this is just a reminder here that any patients with moderate NPDR or mild diabetic macular edema warrant a referral to a retina specialist. Patients have clinically significant diabetic macular edema, meaning their vision is impaired, the swelling involves the center of the retina. They really need to be promptly referred. Also, patients with a lot of hard exudates are considered clinically significant diabetic macular edema. Patients with that severe NPDR have about a 50% risk of going on to develop PDR within a year. So those need to be promptly referred to a retina specialist. And then more urgently, patients with high risk PDR or proliferative diabetic retinopathy with any of the complications we talked about, vitreous hemorrhage, traction retinal detachment, neovascular glaucoma, those patients really need to get in to see the retina specialist immediately. So thank you guys for listening. Again, my name is Scott Walter. I'm with Retina Consultants in Hartford, Farmington, and Cromwell. If you enjoyed this education, you can follow me on Instagram at retina.ct. We've got lots of great content there in the stories and posts. So thank you so much for your attention, and definitely hope to hear some questions if there's time.
We certainly do have time. Let me just remind our listeners that if you want to submit a question to the chat, you can do that, or in the question and answer box, or you can raise your hand. Scott, thank you very much for that talk. Very concise, packed full of information, really useful information. Appreciate that. I'll start off with a question. Our technicians are taking the patient in and taking the history. They may also be responsible for patient education. What are some of the things that they can do to engage the patient more in paying attention to things like their A1C, what their dietary intake is? What tips can we give them?
Yeah, absolutely. I think the A1C is really, a critical, point, because that's something we need to document anyway in the medical record. So we should be asking it at every visit. And I'm always amazed at how many of my patients with diabetes don't know their A1C, don't even know what the A1C is or what it means. So I try to kind of have a little bit of a pep talk with those patients every time I see them. Make sure I'm going to write this down for you. I want you to take this piece of paper to your primary care doctor next time you go and ask them what the number is, so that next time you come, you can tell me. And remind them that their target is to get that number down around 7. Anything over 7 increases their risk of vision loss or blindness from diabetes. So I think a little bit of education around the hemoglobin A1C goes a long way. As far as dietary counseling, I think that that responsibility mainly falls to the primary care doctors. That certainly takes a lot of time to explain how to adjust your diet and exercise regimen and make those lifestyle modifications. But a lot of my patients, if you ask about it, will say they're working on it, and just to kind of be positive and encouraging goes a long way. So they're not just hearing it from their primary care doctor, they're really hearing it from every doctor or healthcare provider that they see. So I would definitely encourage the technicians to engage in a little conversation with our diabetic patients around these issues as they're working them up. And they certainly spend more time in the room with a lot of my patients than I do. So there's a lot of opportunity there for you guys to have a positive impact on the long-term health outcomes. And it's not just about the diabetic retinopathy, because the same thing goes for all the other vascular complications of diabetes. So these patients are at risk for having heart attacks and strokes, kidney failure, ending up on dialysis where they're hooked up to a kidney machine 3 days a week for half a day. It's a big deal if patients end up with end-stage renal disease and end up on dialysis. That's a major impact on their quality of life. So I think anything we can do to prevent those complications, both in the retina and other organs, is really going to have a huge impact.
So true, so true. And many of our technicians are working in general ophthalmology offices or comprehensive ophthalmology offices. And so they're getting patients maybe at different stages too. And oftentimes by the time they hit the retina office, they're having floaters, loss of vision. They tend to be a slightly different patient, slightly different motivations. And so you can make a big difference by kind of focusing the patient's attention on things like blood sugar, blood pressure, cholesterol, kind of that triad, and their A1C. And so regardless of what stage their disease is, there's always some learning that can be done on the part of the patient. So again, thank you. Very, very helpful talk. Do we have any questions from the audience? Okay, well, Scott, thank you again. We appreciate your time, and get back to work and play that music while you're working. That sounded good.
All right, take care, Ed. Thanks so much.
Okay, so our next speaker is Nanani Kambo. Dr. Kambo is a graduate of the Yale School of Medicine and Yale Residency in Ophthalmology. She did a uveitis fellowship with Dr. Stephen Foster at the Massachusetts Eye Research and Surgery Institute. She won an award for humanism in medicine, I think twice. She's currently faculty at Yale on the uveitis service and the comprehensive eye care services. I can tell you personally that Dr. Kambo is kind of our go-to person. She's always so available and pleasant and great to work with. So we really appreciate you spending some time with us today. She's going to talk to us today about the symptoms of uveitis, manifestations, and some of the systemic diseases associated with uveitis in her talk titled The Usual Suspects and Masqueraders. Welcome, Dr. Kambo.
Thank you so much, Dr. Lim, for that kind introduction. And you all know Dr. Lim is awesome. So he's my go-to person for some complicated cases, and we share a lot of lovely patients together. And let me see, Emma, good to see everybody, and thank you for spending your lunch hour with us. I hope this is really a productive meeting for you. And during my talk, I'll encourage you to chime in the chat session. If you have any questions, any comments, feel free to just type away. And of course, if you want to raise your hand, I don't know if I'll be able to simultaneously talk and monitor the hand raising. So if you have a question or anything, I'll pause throughout the talk so that you can have an opportunity to ask questions and we can have a little bit of a dialogue. So we'll get right to it. Still no financial disclosures. I don't know, Edlim, how long this will take, but hopefully one day. I'm kidding. So our talk will, my talk today will focus on, okay, so Marilyn, you have your hand raised. Sorry, do you have a question? Or not yet? Okay. So we'll talk about definitions in uveitis, common causes, as Dr. Lim mentioned, and then I'll outline neoplastic, which means cancerous causes of masquerade uveitis, as well as non-cancerous or non-neoplastic. And then I'll give you some examples. So just a little bit about why I'm so excited about uveitis and why I continue to do it. And everyone who works with me knows how complicated it can get. But even though it's such a rare condition, it turns out it contributes to about 20% of blindness in the US. So we've got a lot of work to do to make sure we treat these patients and treat them well and give them the best opportunity at maintaining good vision. And I thank all my techs who work with me, who help me in that on a daily basis. So once in a while, we have a patient walk into clinic who comes in complaining of a red, painful eye and with light sensitivity that is very significant. So red, painful eye with photophobia. And, you know, I say anyone who tells you that my eye's red, it's light sensitive, it's painful, one of the things that should go through your mind is this uveitis? You know, the first thing is probably a corneal abrasion. We see those a lot and they cause a red, painful, light sensitive eye. But once you rule that out with history, you can think about uveitis. The other important thing is if a patient does complain of a red, painful eye, ask them when their last eye intraocular surgery or intraocular injection was, because we definitely want to make sure we're not missing endophthalmitis in our red, painful eye patients. Anyone want to type in the chat? What do we see down here? I can't even see the chat. Perfect. So thank you, Sarah. So that's a hypopion. And there are different types of uveitis that give us hypopions. The most common one is HLA-B27. So you might see that in the notes of the patients that you're talking about, or they might tell you, yes, I have something called ankylosing spondylitis, or you might actually be the first one to diagnose that they may have HLA-B27. So the questions I do ask my uveitis patients are, do you have morning stiffness? That's usually concentrated on the neck and their lower back. And then the key about this type of stiffness is it actually gets better the more they move. So they'll say, yeah, my mornings are tough. I'm stiff. I try and get out of bed. And then by the time I've been walking around after an hour or so, I feel great and much better. And so that's the key about HLA-B27 or ankylosing spondylitis type arthritis or arthropathies. Another condition that's a little bit more rare than HLA-B27 is called Behçet's, and we see hypopions in that. And then the herpes infections in the eye can give us hypopions, and of course endophthalmitis, which I mentioned briefly. So what's going on in this cornea? Again, y'all can put a quick note in the chat. And awesome. So Kelly, thank you. So these are KPs, and these are large KPs that we see on this endothelium. And I didn't give you a whole picture of the cornea, but you can kind of appreciate that they may form almost like a triangle if you could imagine the whole cornea in view. And this we call Arth's triangle. And the reason we tend to have a concentration of KPs or keratic precipitates in this area is because of the way the aqueous is moving in the eye. It moves with a little bit of convection currents based on the temperature between the outside and the inside of our eye. And they tend to settle there, but you can definitely see them spread out through the entire cornea. When we see large KPs like this, we think of conditions like sarcoidosis, associated uveitis, so the granulomatous diseases. And of course, we can definitely see it in severe herpetic uveitis as well, also toxoplasmosis. So some of the infections will give you these large, what we call mutton fat keratic precipitates, or KPs. Other conditions, syphilis is still alive and well, even after many decades after its discovery. TB, VKH or Vogt-Koyanagi-Harada syndrome, and then sympathetic ophthalmia, which we may be seeing a little more than we used to because of how much surgery we do in the eye, and specifically vitrectomies. We've seen that back in the day when sympathetic ophthalmia was first described, it was actually more common in patients who'd had trauma to their eyes. So a penetrating injury, maybe a nail in through the eye or a projectile through the eye. But now it turns out most cases of sympathetic ophthalmia actually occur in our patients that have had vitrectomies, even just one or multiple vitrectomies. So in contrast, I wanted to show you guys another type of KP that we see, and we call this stellate KPs. The other KPs I showed you were the bigger, thicker, rounder KPs. And these KPs are very fine, and these are scattered throughout the entire cornea. And we see these in several entities. So most commonly are viral. So herpes simplex, varicella zoster, or chickenpox virus. And then in Fuchs, we see this, and then toxoplasmosis infection as well. So let's see. I just want to make sure, am I missing your hand up, Ms. Rosado? It's okay. All right. So the other findings we can see in the eye in uveitis patients are nodules. So these are also granulomatous inflammation in the iris. So you see these fine nodules on this iris, and some actually go all the way out into the angle. And then this picture here gives you a much closer view of these nodules around the pupil. When you treat the uveitis, they actually go away. So it's pretty satisfying sometimes to see when the patient comes in and they have these nodules, and then you treat them and they disappear. The conditions where I usually see them are sarcoid-associated uveitis, but you can get them in lots of different types of uveitis. All right. Anyone want to text in the chat what they're seeing here? Perfect. So thank you. So it's a hyphema. So sometimes in uveitis, we see hemorrhagic hypopyon. So they have blood in them. And the conditions in which we see this is herpetic types of uveitis. So if I have a patient who's coming in with the symptoms of red, painful, light sensitive eye, and I look in, I see this hypopyon with blood, the first thing that goes through my mind is, okay, is this herpes related uveitis? And I usually take, a sample of the aqueous if I need to, and send it for a PCR testing to check for the herpes viruses. So when you see a hemorrhagic hypopyon, if the patient has not had surgery, has not had trauma, think about a herpetic related uveitis. And another thing that herpetic disease can do is actually sort of eat away at the iris. So if you see all these transillumination defects in the eye, you definitely should think about either the herpetic HSV or herpetic varicella type viruses. So for some reason, they damage the iris stroma, and then when you retroilluminate, you can see all these defects in our iris, and sometimes we'll call it a moth-eaten iris. And early on in the disease, it can be very, very subtle. So doing retroillumination is very important. So that was a lot of anterior stuff. As we look into the back of the eye, and when you work in a uveitis clinic or when you suspect any uveitis, even if you see a patient who's telling you 100% the uveitis is in the front of the eye, it's always worthwhile dilating, because oftentimes you'll be surprised by what you see in the retina or in the vitreous, and then that changes your testing, that changes your diagnostic, your differential diagnosis actually. And then of course it changes your treatment. So in this case, we see these little condensations of inflammatory material, and these are in the vitreous, and we call them snowballs. And then when they're all the way on the pars plana, this is called a snowbank. And we see this in classic intermediate uveitis. And some of the patients you may have seen in clinic that we diagnose with pars planitis, this is what we're talking about. So intermediate uveitis and pars planitis. Intermediate uveitis is caused by several conditions. So most commonly we don't know. So idiopathic is what the fancy word we label it as. But in the cases that it's associated with illness, so 8% of the time, the patients may have multiple sclerosis. So you might hear your doctors asking them about tingling, numbness, urinary incontinence. So that's very important to get that in your history. The other conditions that can be associated with intermediate uveitis include syphilis, tuberculosis, and sarcoidosis. So we always ask about those symptoms for those type of diseases. Sarcoidosis, you want to ask the patients whether they have any like nodules on their skin or skin rashes. Do you want to ask them about any difficulty breathing or new cough that has developed? Because sarcoidosis can sometimes affect the skin, it can affect the lungs, and actually can affect every part of the body, to be honest. All righty. So most of what I've talked about is the autoimmune or uveitis, and then I mentioned the herpetic, but toxoplasmosis is actually the most common infectious posterior retinitis. And the history that goes along with this in patients is usually that they do have cats, handle cats, or they eat undercooked meat. And then there are other parts of the world. So for example, South America and specifically Brazil, they've published a ton of literature about toxo. It turns out that it's pretty much endemic there, and a lot of their population is exposed to toxo. Now, we don't quite know why some people will get the retinitis while others don't. That probably has to do with their own immune status and the way their immune system is working. But toxocretinitis, so anything in the back of the eye or our vitreous and retina, the symptoms that patients complain about the most are floaters, blurry vision, flashes. And so when we look in, you see that it's really hazy. And then you see this bright white lesion. So actually we call it a headlight in the fog in the uveitis and retina world. And that's exactly what you're seeing, is that bright white lesion, that's inflamed retina from the toxoplasmosis. And then the haze is because the vitreous, it has a lot of inflammation or cells in it. Another type of infectious uveitis is CMV, which was more common during the height of the AIDS epidemic. And now we mainly see it in our patients who are immunosuppressed because they're on chemotherapy. So this is a lot of retinal necrosis around with hemorrhage. And sometimes it'll be dubbed the pizza pie retina from CMV retinitis. And the treatment is either injecting ganciclovir into the eye and giving them systemic, and then if they're immunosuppressed, trying to get their immune system back working. All right, any questions about the first part? of non-infectious uveitis or comments? All right, so the next part I'll transition to is our uveitis masquerade syndromes. So, and Dr. Lim, let me know if I'm running over time. I think I have till 1 o'clock, right?
You're fine.
All right. So masquerade syndromes is actually a term that was defined in the 60s to describe a very specific entity. It was a conjunctival carcinoma that had presented as conjunctivitis. And since then, you know, we've had other experts chime in, and Nussenblatt was a giant in uveitis, and he described it as conditions that present as apparent inflammation, but are actually not inflammatory whatsoever. And they may have infiltrating cells, but they're not due to an immune-mediated uveitis condition. So those are the conditions that we talked about earlier. Those are definitely uveitis because they are inflammation and inflammatory driven. So we divide these into neoplastic and non-neoplastic masquerade syndromes. And it turns out that 2.5% of patients can actually have neoplastic masquerade syndromes, and they tend to be a little bit older. So average age of about 57, but we've seen younger patients as well. And this is important because in your clinics, if you're seeing a patient come in who's in their 60s, 70s, talking about, I just developed uveitis, make sure you're always thinking in the back of your mind, could this be neoplastic? And you have to make sure you're not missing. And the most common neoplastic condition, of course, being lymphoma, if you have a patient with vitreous inflammation. So other conditions in the young children, retinoblastoma can give us this sort of pseudo uveitis, if you will, or uveitis masquerade. The hypopyon that we saw, sometimes patients with retinoblastoma can come in looking like they have a hypopyon. Patients with leukemia as well, the cells can collect and look like a hypopyon. And then multiple myeloma, lymphoma, as I mentioned. The choroidal melanomas, especially the amelanotic ones, can look like a uveitis. And then metastatic tumors can also. So we know in women, breast cancer can metastasize to the eye and, you know, give us a pseudo uveitis. And then in men, the most common one would be lung cancer. And then prostate and as well can sometimes metastasize to the eye. So in terms of non-neoplastic masquerade symptoms, I divided them into anterior versus posterior. So in anterior uveitis, actually, we just saw a patient with what's called juvenile xanthogranuloma last week. And it's a benign condition, which usually presents in the first year of life. However, the patient we just saw is in her 60s, so it can really present at any time in the patient's side, but most commonly young patients. And the ocular signs will be blurry vision and redness. And then when you look on exam, you might actually see an iris nodule. It's sort of an orangish nodule, and I'll show you some pictures of that. But what can also happen is the patients can develop spontaneous hyphemas. They can also have glaucoma eventually, and sometimes they have these characteristic skin lesions. This condition will resolve spontaneously, thankfully, but for the painful eye, we do treat with steroids, our best friend. So this is the lesion that you can see in the eye. You can see it's a little bit injected and red, but that's the lesion that we're talking about from JXG is the abbreviation for that. This patient actually presented with a hyphema. And then when you look closely, you see the JXG nodule appearing. And then here's one of the skin lesions that can appear in this condition. So you see this little one with that nodule on their chin. And then here's the same kid, you see the little JXG nodule right there. And this is one of our patients that we saw. He was 12 years old, and you see the little tannish orangish lesion here on the iris. And he was coming in because of intermittent redness and then some cells in the anterior chamber. And then we saw this lesion. And after several weeks of steroid drops, this lesion completely disappeared. And he's doing great. So the next syndrome that you all who work in the glaucoma clinics a lot might have come across is pigment dispersion syndrome. So these patients usually will complain of intermittent blurry vision. The classic is sort of the young myope who notices blurry vision when they participate in activities, sports activities. So jogging, basketball, anything that's pretty vigorous. And when you look into their eyes, you will see some sort of cells, but the important thing is they're pigmented. You know, they're not white uveitis inflammatory cells. The patients are usually in their 20s to the 30s, and sometimes they actually do have light sensitivity when their pigment dispersion syndrome is acting up. And the treatment that you, actually the exam findings, which are important to first look at, is you can see pigment on the endothelium. So you see these little endothelial pigment deposits, which you call the Krukenberg spindle. And you can also, when you do gonioscopy, see a very heavily pigmented TM. And that gives you a clue that there's a lot of pigment being liberated. When we dilate the pupil and look at the anterior hyaloid, we can also see some pigment deposits there. So all these findings will help you move away from a diagnosis of anterior uveitis, because you'll see all these clues that, you know, it's actually pigment liberation. And the arrow sign, just to point out all the findings we're talking about here. And then also, this is courtesy of our own Dr. Liu here. When you look, or when you do your retroillumination, you can actually see these little fine, and here too as well, you can see these iris defects. So transillumination defects, you have to take your time to really look for them. And they're classically in this area in pigment dispersion syndrome, so in the mid periphery. And then here is, you know, when you've had pigment dispersion syndrome for a long time, or it's been pretty active, you can, the transillumination defects are really much bigger than the ones you see in this picture, where they're really tiny. So anyone want to put in the chat why we get the TIDs, or the transillumination defects, in PDS? We'll do the glaucoma techs. Any glaucoma techs in the house here who can answer that? Yeah, so Lorena said zonules rubbing against the iris, and that's exactly it. That's what's happening, is every time the iris is moving, it's rubbing the zonules, and then the pigment is being released. So thank you for that. If we don't have those signs that I just showed you, which can take some time to appear, you might be clued into the fact that in addition to the patient being myopic, they also, this does not respond to corticosteroids, of course. And then all of you who've worked in the glaucoma clinic have seen that the treatment really will be laser. And then, you know, I don't know what else they do if laser doesn't work, if an LPI doesn't work. We can ask the glaucoma crew later. So another thing that can masquerade as uveitis is a retinal detachment. There's a chronic RD, there's the eponym Schwarz-Matsur syndrome, where it turns out that the photoreceptors can be floating around and actually blocking our trabecular meshwork, then causing subsequent IOP elevation. So as I mentioned earlier, even if you see cells in the anterior chamber, you've got to dilate the patients because we got to see what's happening in the back of the eye and make sure we're not dealing with this syndrome. So as always, for inflammatory or elevated IOP conditions, you have blurry vision, eye pain, and then the history in these patients, of course, you can ask them about previous trauma or whether they're post-op patients. We know RDs can happen in our patients. And then it turns out that atopic dermatitis might be a risk factor for having this RD. And when you do your exam findings, in addition to your elevated IOP, you'll see AC cells, and then the open angles will be open on gonioscopy. And then if there is a history of trauma, you may see angle recession. And then of course, the definitive diagnosis will be made when you find your break in the retina. So, and of course, we treat the RD and then we're all good, or the patient does well. So another syndrome, ocular ischemic syndrome, which tends to give us some, which is a uveitis masquerade, and patients present with pain, redness, and blurry vision, and then they might describe intermittent loss of vision or blacking out of the vision, which is called amaurosis fugax, and then also acute decreases in vision. These patients with OIS tend to be older because the risk factors are, cardiovascular. So if they've had atherosclerosis, uncontrolled hypertension, diabetes, these all contribute to OIS. And these are findings in a patient with OIS. So the red eye, like we talked about, and then they might have neovascularization of the iris. And you can see this is an FA imaging the iris. So you can see all the new vessels or neovascularization in this iris. And then here's a picture of it. And also they tend to develop a unilateral cataract as well. In the anterior chamber, what might make it look like a uveitis is you see some cells and some flare, and that's probably just from the compromised vasculature and the neovascularization. When you look in the retina of patients with OIS, you see all these hemorrhages in the retina, so all these dot blot hemorrhages from the ischemia. And then you can see on FA really delayed filling of the vessels here, as well as in the choroid. So when we see patients like this, what we do, the most important thing is actually to send them for carotid imaging. So you want to investigate whether there's stenosis in the carotid on that side where you're seeing the ocular ischemic syndrome, so the patient can be treated appropriately with endarterectomy if that's needed, or if the occlusion is less than 100%. So we have a condition called ocular amyloid, which really we see in younger patients, and the systemic issues that these patients will have are sensory motor neuropathy and paresthesias. And also the thing to go first is thermal and pain sensitivity, and then also the cornea. So they'll lose corneal sensitivity as well. And because they have no corneal sensitivity, as you've seen with other conditions with neurotrophic corneas, they tend to get ulcers. But on exam, we'll see amyloid deposits and tortural retinal vessels, and they can also develop glaucoma. So here's some deposits of amyloid in the vitreous here that we can see. And so you might think when you look at this, that the patient has vitreous cells, but if you put everything together, you can see here, the history of the neuropathies, corneal hyposthesia, and these, you can sort of put that all together. Here's a picture just to demonstrate what the amyloid looks like, and you'll see it here. It just gives you that deposits within the vitreous, and sometimes they are in just sort of clumps versus the little dots that I showed you, or the spots that I showed you here. And then RP, or retinitis pigmentosa, is usually we see some sort of pigment changes in the retina, but there is an RP that does present with no pigment. And so in this case, this patients can also have some vitreous cells, some depigmentation, some PSC, and then some cystic macular lesions as well. And of course, in uveitis patients, they may have vitreous deposits, they may develop PSC from inflammation, and they may have CME from inflammation. So the RP without pigment might masquerade as a uveitis because of those findings. And of course, we know that in retinitis pigmentosa, these patients may have a lot of trouble with night vision. You'll do a field, you'll see defects, and then you can do your ERGs, and of course, see defects in the photoreceptor function as well. And here's an FA of that. And then one last entity I'll touch on is hypertensive retinopathy that can masquerade as a retinopathy. These patients will have blurry vision, painless loss of their vision. And on exam, you might see vit-heme, choroidal ischemia, retinal edema, all of which you can see in uveitis as well. And so this is just to demonstrate several different types or levels of manifestation of hypertensive retinopathy. So remember that CMV picture I showed you earlier. Sometimes you might look at this picture and think about that. When we see pictures like this, lupus vasculopathy, which I didn't show you, can also give us these types of scenarios. So you might think it's a uveitis. And this is a milder, so around the nerve, we see damage, we see vascular attenuation. And then in this patient, we see a little bit of the vessel changes. And then of course, the cotton wool spots as well. So hypertensive retinopathy can, really damage the choroid. And then in this case, we see some choroidal infarction that can occur as well with acute hypertensive changes. So of course, taking the blood pressure will answer our question here. And then when we see retinopathy of these grades, we definitely, and of course, the blood pressure, these are all hypertensive emergencies. So these patients must be taken to the ED right away for blood pressure control. And then here's the choroidal infarction. So sometimes if you see that, you might think that maybe it's some sort of retinitis or choroiditis. And so in summary, when you want to consider masquerade symptom or syndrome, when symptoms don't match up or when there's no response to standard therapy, and as you know, most uveitis, it's steroids. So if the steroids are not helping, you have to go back to the drawing board. Of course, if the steroids are making it worse, then it's a whole nother issue. They can mimic anterior uveitis, but the most common type of uveitis that masquerades mimic are posterior uveitic entities. So as I mentioned earlier, think about the age group that we're dealing with. New uveitis in the 5th, 6th, 7th decade should always raise the question of whether this is a masquerade, and specifically a neoplastic masquerade. And of course, in uveitis, it's all about the history taking and the thorough eye exam, and then all the testing that we have available to us is very helpful too. So I thank you for your attention today, and good to talk to you guys. And then thank you, Terry, for commenting about the child with JXG. Okay. You know what? That's a good question about whether JXG will ever go into the eyes. I don't know, and I haven't seen anything published about what the incidence of ocular involvement is in this population, but I haven't looked recently, so I don't know if anything's been published in the past 2 years. I haven't really looked it up recently, but I don't know. That's a good question. And also the kid I showed you that we saw who was 11 had not had any skin lesions in their life. And the woman that we just saw last week has never had any skin lesions. So I don't think you have to have every manifestation.
The great variability of disease presentation. What a great talk about such a vast topic. You made it understandable and clear. So I really appreciate that. Thank you, Dr. Combo. I have one question for you briefly. Yes. You know, well, I think about our technicians, they're in the room doing the intake and taking the history. Is there one or a group of signs or symptoms where you would like it if they would come and tap you on the shoulder and say, you need to come and look at this right now?
Yeah, absolutely. That's a great question, Dr. Lim. So I think, as I mentioned earlier, the really most important symptoms for an anterior uveitis, if a patient has red, painful eye and they're light sensitive, that really should get some bells going off. And what the intake tech can ask is, you know, any history of trauma, so a corneal abrasion, because that can be similar or present similarly. And of course, if it's a new patient, you definitely want to get that. I tell people the 3 high yield questions for a red painful eye: do you wear contacts? And if it's yes, do you sleep in them? And just quiz them about their hygiene, because it might be an ulcer. The other question is trauma, you know, has anything hit your eye? And then surgery. You know, some patients, and specifically intravitreals, we know if you look in Connecticut alone, they're probably doing about 1,000 a day in Connecticut. So those can put the patient at risk for endophthalmitis. So definitely red painful eye should make you think of uveitis, but you rule out those 3 conditions. And then also floaters really should make you think about some type of uveitis going on in especially intermediate, if the patient is not talking about a floater that just comes and goes. Now you're talking about constant floaters. So that would be one thing to differentiate, because we know a lot of our patients have floaters and they're not uveitis. But if they're floaters that are just constantly there, not going away, and they're new, then we should make sure we dilate our patient, or just nudge your doctor and say, I think even though they're here for, you know, IOP check, we might need to dilate. And then also the one thing I wanted to mention is flashes. So flashes are never normal. And if you've looked at the retina, there's no tears, no holes. I think anyone with constant flashes needs at least a baseline FA, just to make sure you're not missing a subtle retinal vasculitis, especially in actually in any patient, but definitely sometimes we have an anterior uveitis patient who has flashes now and then. You've got to just do an FA to make sure there's no vasculitis.
Wonderful. Thank you so much for your expertise and your time this afternoon. I hope you enjoy the rest of your day. We're going to move on to our next speaker, Christy Mascarenhas. Dr. Mascarenhas did her ophthalmology residency at New York University, Manhattan Eye and Ear and Throat Hospital. She returned back to Yale University for her glaucoma fellowship. She's a clinical faculty member currently at Yale University School of Medicine. She has offices in Middletown and Westbrook. And she's going to speak to us today about essential elements of technician workups for new and returning glaucoma patients in her talk titled Glaucoma Workup for Technicians. Welcome, Dr. Mascarenhas. Oh, you need to unmute your mic.
There we go.
Wonderful.
Thanks for having me, Dr. Lim. Here we go. Okay, so I'm Christy Mascarenhas from Middlesex Eye, and I'm here to tell you all the things you may or may not want to know about glaucoma workups for techs. So I have no financial disclosures. So why is the tech workup so important in glaucoma? One of the things you'll hear primary doctors say about their exams, and I'm talking primary medical doctors, is that you can get 90% of the information you need to make a diagnosis actually while you're talking to the patient and getting a history. So glaucoma's got a lot in common with primary care. It isn't exactly like primary care, but it actually isn't so different. So depending on what a patient says during the history, it might lead us toward or away from particular diagnoses like glaucoma versus not glaucoma, or we might actually get a good idea of whether their glaucoma is stable or needs treatment or needs surgery. And since techs have the first contact with the patients beyond the front desk a lot of times, you get the first and best chance to establish a relationship with them and establish a basis for trust. So you also get the first chance to start digging for that gold mine of wonderful information that helps us take care of them. So going through all the parts of the tech workup, first is the chief complaint. So short and sweet, why is the patient here? Do they actually have glaucoma? Do they know they have glaucoma? If so, how long have they had it? So two basic elements of the chief complaint, what and for how long. If they're not sure, did somebody refer them for a second opinion, like a local optometrist or a primary care provider? If they were referred, what made the referring doc suspect glaucoma? Did they have high IOP? Did they have narrow angles? Did they have funny looking nerves? And how about any of the symptoms that the patient may have noticed? Do they have any pain that might make you think of intermittent angle closure? Are they complaining about blurry vision once in a while, like Dr. Combo mentioned about pigment dispersion? When somebody exercises, they might get blurry vision. Do they say they have blind spots somewhere in their vision? So sometimes different types of glaucomas tend to happen more often in different types of refractive errors. So we want to know, do they wear glasses? Do they wear contacts? If their glaucoma is unilateral, I always want to ask about a history of eye trauma, which often leads to a unilateral glaucoma. Do they have a family history of glaucoma? And then the other thing we want to know is if they do, did anyone in their family lose vision from glaucoma? Because that can run in families as well, severe types of glaucoma. So beyond history of present illness, we want to know about their medication history. When it comes to medications, of course, we care about their eye drops, including all the ones that they can remember using in the past. Now, remembering can be really hard, especially if they've had glaucoma for decades. If they can't remember the names, and a lot of times they can't, sometimes they can remember the colors of the bottle caps. So it's always nice to be able to ask about those and know in general what color is what. We definitely care about the systemic medications they're taking. A lot of those can affect the eyes. Now, I always want to know if somebody's taking chronic steroids, since those can raise IOP, but also anything that might push someone towards angle closure. So those could be almost any antidepressants. A lot of medications for overactive bladder can do that. And also over-the-counter decongestants or antihistamines for somebody who has chronic allergies. Also, since some people don't necessarily think about medications that they don't put in their mouths, I'll always ask about over-the-counter steroids in other forms too, nose sprays for allergies, steroid creams for rashes, even injections into their joints for arthritis. I have some people who respond like clockwork every 3 months when they get a steroid injection for arthritis. Thinking about all their past drop use, we always want to ask about allergies to drops too, so that we don't repeat past mistakes. So you can be allergic to any drop, but there's one that's notorious for delayed allergies. Specifically, we call it follicular conjunctivitis, and that can happen years after you start taking it. That drop is bromonidine, purple drop, purple top. So the other difficult thing about drops is adherence, and that gets more difficult the more complicated we make their drop regimen. So I'll ask how many times a week people miss their drops, and especially whether they used them the day of the appointment. I still have some people who skip their drops on the day of an appointment because they think I want to see what their eyes are like without the drops. And that way, if I know that their pressure is not doing so well the day of the visit, I don't panic necessarily if I know that they skipped their drops. So here's a nice rainbow of bottle cap colors. Thank goodness we have them. And here's a chart with the most common eye drop classes color-coded. So starting over here, these red top drops or mydriatics and cycloplegics, those aren't that common to have at home, but if you have somebody with uveitis, you might have them on cyclopentolate or cyclogel. If you have somebody with a chronic blind painful eye, they may be on atropine, which also has a red top. Your orange tops are going to be carbonic anhydrase inhibitors, azopt, brinzolamide, dorzolamide. Yellow tops are going to be 0.5% beta blockers, timolol, and all its equivalents. And then over here, you have kind of light green alpha agonist combos like Simbrinza. Your gray will be NSAIDs. Your Kelly green over here will be miotics like pilocarpine. Then there's light blue, 0.25% beta blockers. This isn't such a great color, but over here you've got your aqua green, which would be prostaglandin analogs. And then white tops could be just about anything. Unfortunately, some companies do choose to put white tops. Dark blue will be a beta blocker combos, so things like dorzolamide timolol or brand name Combigan. Purple will be your alpha agonists. Pink top usually means a steroid. And over here, tan top will mean an antibiotic or sometimes an antibiotic steroid combo. So sometimes if you ask patients about bottle cap colors, you'll get a better idea of at least what class they're on, if not the specific medication. So then on to past medical and surgical history. There are lots of medical problems that can affect the eyes and affect glaucoma especially. So I'll always ask about sleep apnea. That OSA is obstructive sleep apnea, and that's a risk factor for glaucoma. Sadly, it seems that treating it doesn't make the glaucoma any better, unfortunately. Also, low blood pressure and migraine are a couple of systemic illnesses that are risk factors for low pressure glaucoma. COPD and asthma aren't actually risk factors for glaucoma, but if a patient has them, I want to know about it because I'll be reluctant to use beta blocker drops. Those can actually make the COPD or asthma go out of control if it's on the borderline or it's severe. Surgical history. We want to know if they've had cataract surgery and also LASIK or PRK. So refractive surgery like LASIK and PRK can thin the cornea, and that means we'll be underestimating the pressure. So if you think about a Goldmann tonometer, it's got a flat surface. The thinner the cornea is, the easier it is to flatten with your tonometer, which basically means it'll push back less at you while you're checking the pressure. And that means regardless of what the actual pressure is, you'll think it's a bit lower than it is. So of course, we want to know if they've had glaucoma surgery or laser in the past so that we can tell whether that's something that we can repeat or not. And sometimes they may not know, but we can also ask about other eye issues that might affect IOP measurement. So if someone has Fuchs endothelial dystrophy and their corneas are swollen, that might cause us to overestimate IOP for the opposite reason of the thin corneas. And keratoconus could actually make parts of patients' corneas thinner and also make pressure measurements inaccurate. And social history can actually be pretty interesting as it relates to glaucoma. So in the last couple of decades, the number of people using complementary and alternative medicine to self-treat their glaucoma has really increased. That's something that we want to be aware of if that's something that they're doing. Everything on this list here is something that some patient of mine has said that they've used for glaucoma in the last 10 years. Hang on 1 second. So some of the names you might hear are ginkgo, bilberry, mirtogenol, forskolin, resveratrol, and there are many more. So the trouble is that the evidence for these things is kind of mixed at best, and a lot of them do have negative side effects. So it's something that we do want to be aware of. So asking about marijuana can also give you very interesting information. I always like to know if someone has had any specifically on the day of their appointment, because that can actually lower their IOP for at least a few hours. The problem, and one of the reasons why we don't give it for glaucoma in the first place, is that it can also lower your blood pressure, which isn't always good for your optic nerves if they're not getting the blood flow that they're supposed to. If I know someone uses marijuana occasionally for other things, I might ask them to try not to on the day of their appointment, unless they're using it for, say, anxiety or PTSD, so that I can make sure their IOP is low enough during the times when they're not taking any. Often patients will also ask about other lifestyle choices and substances that might affect glaucoma, and I know some of our techs have had questions about these too. So caffeine can raise your IOP, but you'd have to drink a lot of it right before your appointment for me to see the effect of it when I'm measuring your pressure. Alcohol can actually lower your IOP in the short term, but it seems that heavy chronic alcohol use is actually associated with glaucoma progression. And then cigarette smoking is also associated with higher IOP. So then we move on to the tech portions of the exam. So the first part of any exam is you want to read their glasses. You want to know what kind of glasses prescription they have if they're wearing any. Some glaucomas, like we mentioned, are associated with particular kinds of refractive errors. So for a high hyperope, you want to be aware of the possibility of narrow angles, and that would happen because hyperopes have a shorter, more crowded eye. For young adult myopes, like Dr. Combo was mentioning, they may be more likely to have pigment dispersion. And just answering her question about pigment dispersion, in young pigment dispersion patients, the laser iridotomy is something that we can do to separate their iris from their lens and prevent some of that chafing and pigment dispersion. It doesn't always lower their IOP, but once we've done that, we treat it just like any other kind of glaucoma. They can have eye drops to lower their pressure. We can cautiously do SLT, and we can always do glaucoma surgery if all those things fail. And then in high astigmatism, you might start thinking, do they have keratoconus? And there you might want to check IOP differently so that you're not getting confounded by the keratoconus. So sometimes what we think about is actually measuring IOP twice. If you take your Goldmann prism and first measure the IOP with the prism horizontal and then turn it and measure it 90 degrees vertical and then average the measurements, that can give you a little bit more accurate IOP measurement. So you want to check their pupils, of course. And if you think there's an APD, and it doesn't take much to make an APD in glaucoma, just a little bit asymmetric visual field defects, you want to get confirmation of that before you do anything to change the pupils in a way that your doctor won't be able to see that APD if it's there. If we're still not sure that somebody actually has glaucoma, sometimes checking color vision can also help differentiate between a glaucoma diagnosis where you'd be less likely to see color vision affected and a neurodiagnosis where you might actually see the colors are down. A confrontational visual field can sometimes help us confirm a visual field defect when an automated visual field is unreliable. And I had that recently on a young patient. I think everyone should have pachymetry on their initial exam. So we talked about this a little bit already. Average corneal thickness is around 540 microns. As we already talked about, if your corneas are a lot thicker than that, we start calling them corneas of steel because they're harder to flatten with the tonometer. Regardless of what their actual IOP is, that will make you tend to overestimate their pressures. A lot thinner than 540, and we may underestimate the IOP. We don't actually go correcting usually for those thicker or thinner corneas, but it's nice to have that in your mind when you're wondering, A, whether I treat somebody, or B, whether they're actually controlled. For me, when I first meet a glaucoma patient, I don't like to meet them when they're already dilated. I like to do a gonio first. Sometimes if their eyes are already dilated, I miss important findings on gonioscopy if their angles are crowded. But the other thing about dilation that we really, really don't want to do is if we dilate somebody with narrow, potentially occludable angles and put them into angle closure. So here is this repeat customer that nobody wants to see. This is someone who was here for a dilated exam a few hours ago, and now their dilation is wearing off. They're in a lot of pain. They can't see too well. They might be throwing up because of the pain and the high eye pressure. And here are all the classic findings of acute angle closure in that right eye. So there's lots of hyperemia. The cornea is all swollen and cloudy. You can't see the details of the pupil and the iris that well, but you can see that the pupil is mid-dilated compared to the other eye. That's usually because it got stuck on the thickest part of the lens as the dilation was reversing, and that's what we call pupillary block. On exam, you'll find that their IOP is very high. The highest I've ever seen in angle closure was in the 80s, and they have a closed angle if you are able to get a look through all that corneal edema. This is not what we want to do to anyone, especially a new patient that we've just met. So this is a really good thing to go and get your doctor for. If you think somebody has narrow angles, it never hurts to ask somebody to double check. That's not something that I'll ever get upset about if it means that we avoid angle closure later on. And then the last part of the exam that you might be involved in as a tech, I kind of skipped over the whole doctor part of the exam, is the ancillary testing. So for narrow angle suspects, we might want something like anterior segment imaging. For everyone, I like to get disc photos at least once for a baseline, and sometimes we'll repeat them later on as well if we have a good fundus camera. If I'm trying to diagnose glaucoma, I'd like an RNFL OCT at the first visit, since that's the test that most likely will show early glaucoma damage. You could actually lose 50% of your retinal nerve fibers before you start to have visual field problems. So that will be your most sensitive way of really diagnosing glaucoma early. Then on the second visit, I'll get them a visual field to stage their glaucoma or confirm that their visual field is normal in early glaucoma or for a glaucoma suspect. And here are some of the common visual field defects in glaucoma. So any of these can appear above or below the horizontal midline. So over on the left, there's a nasal step. In the middle, there's an arcuate scotoma, which you can kind of think of as a nasal step that kept on growing. On the other side, on the right, there's a central scotoma, and that's a little bit confounding. You can also see that in things like macular degeneration. Central or paracentral scotomas can also appear in nutritional deficiencies, but it also happens to be pretty common in low pressure glaucoma. So none of these would surprise me to see in a glaucoma patient. These visual field defects are a little bit different. So if you see these, glaucoma should not be the first thing that comes to mind. So over on the left is a homonymous hemianopia. Homonymous basically means that if you take these visual fields and lay them on top of each other, right over left, they'll match. If I see a visual field that looks like that, the first thing I'll ask a patient is when they had their stroke. If they don't know of any neurological problem that they had, I'll get them a scan of their head to see what might be causing this that's in their brain. So classically, when you see something like that, this is not caused by something in the eye. It's a brain thing. The one on the right is a bitemporal hemianopia. So here and here on the visual field. For this one, I would think of a problem with the optic chiasm, which is the place in the brain where some of the fibers from the left and right optic nerves start to cross from one side to the other. Your pituitary gland lives right near the optic chiasm. So a bitemporal hemianopia most often means that there's a pituitary tumor that's pushing on the optic chiasm, or that there's a bleed in your pituitary gland. So last thing, we'll go over these self-assessment questions. So if people want to put the answers in chat, you can do that. Which type of visual field defect is not commonly seen in glaucoma? So we just did these: a superior arcuate, a central scotoma, bitemporal hemianopia, or a nasal step. Yep, so bitemporal hemianopia, great. And which commonly used substance will raise your intraocular pressure? Caffeine, tobacco, alcohol, marijuana, or A and B? Yep, A and B. Okay, here's a patient that is the last thing you want at 5 p.m. on a Friday. They had a dilated exam earlier in the day. This is acute angle closure glaucoma until proven otherwise. Which is not a symptom of acute angle closure glaucoma? Blurry vision and halos around lights, flashes and floaters, red eye, or nausea and vomiting? Yep, so flashes and floaters. If you see flashes and floaters acutely, you want to think retinal detachment. All right, so here's a patient who's red, irritated, tearing, hasn't changed glaucoma drops in a few years, but here are some glaucoma drops. Which of these is most likely to cause that delayed follicular conjunctivitis even years after starting? Latanoprost, timolol, brimonidine, or dorzolamide? And that one is brimonidine. Last question. Get rid of this. So what is one clinical implication of measuring central corneal thickness or pachymetry? Does thicker than average corneas mean that we're overestimating IOP? Does thicker than average corneas mean that the patient might have had refractive surgery? Does thinner than average corneas mean that the patient has Fuchs? Or does thicker than average corneas mean that the patient has keratoconus? Yep, so thicker than average corneas of steel means that we're overestimating IOP. All All right. So thank you for coming to this virtual talk. And thanks to Dr. Lim and Deb again for inviting me. I think we're all hoping for fewer socially distanced eye exams soon, and hoping we can go back to CSEP in person soon too.
Thank you, Dr. Mascarenhas. Really practical information. Love the talk. I think our techs will really benefit from that. And you scared me a little bit with the test at the end. Got that test anxiety going again. Thank you for your time. Our next speaker is Noman Chowdhury. Dr. Chowdhury is a product of Yale University residency program. He went on to the Bascom Palmer for his fellowship in retina, and he's assistant clinical professor in ophthalmology at Yale, and he's a personal friend of mine. It's just wonderful to see him. He's always such a thought leader in our state, and it's great to have him in the community of retina to refer to. He's oversees the biggest clinical research center for retinal and macular diseases in Connecticut. And so I'm sure many of you have heard of him and his practice in the past. He has offices in Waterford, Guilford, and Norwich, Connecticut. And he's going to talk to us today about OCT findings of common retinal and macular diseases, and then cover some vision-threatening conditions and how to recognize OCT artifacts that may mimic some of these diseases. And he'll do this in his talk titled OCT Findings of Common Retinal Disorders and Pitfalls. Dr. Chowdhury, welcome.
Thank you. Thank you, Ed, for the kind introduction. I hope everybody can hear me. So the artifact part, I was looking through the program, and there is another talk on that. So I'm going to do some of it, but not all of it. So hopefully leave something for the subsequent speaker. So we're going to start. I will start with my financial disclosure. I'm a principal investigator for all these clinical trials, so some of that will be mentioned. This is, OCT is very commonly used nowadays for different eye problems, glaucoma, retinal diseases, macular diseases. And it is important to know when you do the OCT of the macula because what it really shows, because you can not only diagnose a lot of problems, but a lot of the things which are abnormal are within the normal spectrum of things, and not everything needs to be fixed. So sort of just to remember, when you do an OCT scan of the macula, the inner part is called the inner retina, and then the outer retina. And this white sort of base is the RPE, and then that clear area in between, and then there's another white line. That black and white line is really the photoreceptor. So that area is very critical. If that area is damaged, then there's a bigger problem at hand. Just to sort of remember, it's hard to remember all these lines. This is a very common thing we see all the time. It's a retinal detachment. It's also called a rhigmatogenous retinal detachment. And it's a surgical problem which needs to be fixed with surgery. And you see these hydration folds, these undulating sort of folds in the retina. Those are called hydration folds. Why is it important to know that? Because when you see the hydration folds, that usually means that there's a break in the retina, and that is a surgical issue which needs to be surgically fixed. Also, after surgery, also when you do an OCT to a retinal detachment, you can actually see that that's sort of the choroid, and the whole retina is detached, and you see these hyper reflectivity of the photoreceptors. They are under stress. Whenever photoreceptors are under stress, you see you can actually see them, and you lose that two line, the dark and the white. They all become like one line, a white line, and that's usually photoreceptors under stress. And when you fix a retinal detachment, you can actually see sometimes these hydration folds. That's why I was showing you that sometimes the post-retinal detachment repair, you do an OCT and you see these lines. Those are the hydration folds, which over time will disappear. Also, when you have an eye with silicone oil, sometimes you will see this shiny interface of the OCT and the vitreous cavity. It's not an epiretinal membrane, I will show later. So OCT is very helpful in many cases in differentiating between a retinal detachment versus a retinoschisis. Retinoschisis is splitting of the retina. So part of the retina is still attached to the back wall, and part of the retina is elevated. And that is common in 4% of people above 40 years of age. And in the majority of the patients, you do not need to fix it. How do you differentiate? Sometimes you can't tell. OCT can be very helpful. As you can see here, that you can actually see to that area that part of the retina is still attached to the back wall and part of the retina is up. So that's why OCT is helpful in a retinoschisis versus a rhegmatogenous retinal detachment. So this is a 38-year-old patient who's a diabetic who came in with blurry vision in the right eye. Vision was 20/25 in the right and 20/20 in the left. And you can actually see in the right eye, he has some swelling or macular edema, and left eye also has a little bit of macular edema. So in diabetics, OCT is very helpful because diabetic macular edema is the most common cause of visual loss in diabetics, and if not treated appropriately, can cause progressive loss of irreversible loss of vision. This is a fluorescein of the same eye. You can see perifoveal microaneurysms in both eyes and late leakage. And same patient, so initially we observed him and then COVID hit, and he came back 4 months later. And you can see his macular edema in the right eye got a lot worse. And you can see on the map, there's significant edema in both eyes. So these patients are usually treated with intravitreal anti-VEGF. So he was started with Avastin, and he had 2 injections, and he had not much improvement in the left eye. And because of that, we switched him. But this is more about macular edema. When you do the OCT, you can see that umbo of the fovea is not there, and you can see cyst. And also, sometimes you see hard exudates looking like that. So diabetic edema OCT is very important in not only diagnosing, but also monitoring these patients. And because it's a chronic condition, it ebbs and flows, but it can disappear and then can come back. And that's why serial OCTs are very important in these patients. This is another patient, diabetic, who came in, and in this patient, not only that he had diabetic macular edema, you can see, but he also has subretinal fluid. This is called stage 2 diabetic edema. It is so severe that not only within the tissue of the macula, there is these cysts, which are macular edema, but there's subretinal fluid also. Same thing in the right eye. And if you look at this red free, which you get, you can see these abnormal lacy vessels developing all around in this eye. So this patient not only has diabetic macular edema, but also has proliferative diabetic retinopathy. And this is a fluorescein. You can see that the diater, there's significant leakage along the arcades in both the eyes, early and late frames, with very aggressive. So initially, question was what to do. So this patient was treated with a combination of intravitreal anti-VEGF and PRP. And you can see this is about 6 months later, no surgery done in this patient, just with aggressive laser in both eyes and anti-VEGF therapy, we were able to achieve stabilization of the macula and regression of the active blood vessels. You know, in the old days, this eye would have required surgery, but with this modern serial anti-VEGF therapy and OCT monitoring, you can really do wonders and save the patients from surgery. And this is the same patient early on, and now later, you can see most of these blood vessels have regressed and stabilized. One other thing which has been described is called drill. Drill is a word for disorganization of retinal inner layers, and that has been described in diabetics, but it can apply to other retinal problems also. And in really bad advanced diabetics, you can get such disorganized inner retina that you can't even make out the layers. You can see here, I mean, this is after therapy, you can start to see all these layers, but here you can't really make out these layers. And there's some more severe cases in which there's really no anatomical landmarks. Drill is an independent, poor prognostic sign for these diabetic patients. It may or may not be present with ischemia. In the old days, we used to think that drill was irreversible. However, there have been in the DRCR and then some other trials, it was shown that with aggressive anti-VEGF therapy, some of the drill can be reversed. So these patients who look like with this diabetic edema and these cyst formations. In the old days, you used to throw up and say, you know what, we're not going to throw your hands and say, can't do anything. I think with an aggressive treatment, some of these patients can be restored and vision can be improved. So this is a patient with significant ischemia on OCTA, and you can see that you cannot even make out the lines, especially temporal macula. So this is drill. Drill, as I said before, is a poor prognostic indicator. This is a patient you may see in which you can actually see this is an OCT, and you can see that the outer retina layers in this area on both sides are sort of gone, disappeared. It's also called the flying saucer sign. And this is typical for this patient, a patient who have been on plaquenil or hydrochloroquine toxicity. Hydrochloroquine or plaquenil is a very good drug. It's steroid sparing, it's immunosuppressive sparing, and usually you have to be on plaquenil for long periods of time to develop toxicity. After 5 years, it's only 2% risk. After 10 years, only 4%. And after 20 years, there's only a 20% risk. So the overall risk of developing plaquenil toxicity is very low. However, if you get it, you have to diagnose it very early, because even when you stop the drug, it progressively gets worse. So that's why you have to be very aggressive in following these patients. And this is a patient we saw, the initial picture I showed you, and you can see usually when you do the OCT, the best way to do the OCT is do linear scans all the way through. And usually it's on the temporal and sometimes on the nasal side of the fovea with horizontal scans, and you can see loss of the inner retina. Very important tool for monitoring plaquenil toxicity. And you want to see it early. You don't want to get to this stage in diagnosing these patients. Same thing, same patients. As I said, it's infrequent, but it's irreversible, usually with high doses. And if you have other retinal problems like macular degeneration, you're more prone. And this is a patient over time developed toxicity. As you can see, slowly he lost a lot of his inner retina. Initially it was very focal, but as time went by, he lost more and more. Very important. And in these patients, every 6 months, they should have the OCT, central visual field. And if you have the setup to do visual evoked potential also, you can see lots of loss of visual evoked potential also. And on the visual field, you can see loss of a visual field also paracentral. That brings us to the third category, which is vitreous interface issues. And this is a patient who comes in with some distortion in the left eye. Right eye, you can see it looks okay, but the left eye, the vitreous is attached to the macula and it's causing a macular cyst and distortion. So just to get all the terminology right, there are 3 stages really. Vitromacular adhesion, in which you do an OCT and you see the vitreous attached. This is the normal finding in majority of people you see, and it in itself is not, it's not pathological. As the vitreous starts to liquidate and it starts to get worse, it can actually cause some traction on the fovea if it is abnormally attached to it. And the patient may or may not have symptoms, and that is called Vitromacular Traction. And if it gets severe enough, it can actually cause a hole in the macula. So it's kind of a spectrum. Adhesion is mild and usually not significant, and whole macular hole is obviously a big problem. So when you have chronic vitromacular traction, you can start to get changes in the fovea. When you clinically look, it looks like a macular drusen or a vertiliform lesion. And on OCT, you see what's called the cotton ball sign. What it is the photoreceptors are under stress, and over time they degenerate. And that's exactly what happens in macular degeneration also. So that's what's happening in chronic vitromacular traction. And you want to get to these patients beforehand because some of the visual loss is irreversible. This is a patient, but not everyone needs to be operated. This is a patient who came with, who had vertiliform lesion in the macula and had vitromacular traction and an epiretinal membrane. I recommended observation. And over time, there was spontaneous separation of the vitreous, and it stabilized. Vision was 20/40, and the patient was happy. No surgery was done on this patient. Nowadays, about 7-8 years ago, there was this drug approved called Jetria, which was injected into the eye for inducing a vitreous detachment for patients with vitromacular traction. However, there's another case of a drug getting approved by FDA, and later we found out that there were toxicity. Some of these patients were developing spontaneous lens dislocation, retinal detachment, severe peripheral photoreceptor loss. So nobody uses it anymore, and it is off the market. Also, you can use gas bubble to induce a vitromacular traction, but recently there was a trial going on with the diabetic DRCR trial in which they showed that almost 15 to 16% of patients with vitromacular traction and stage 2 macular hole, when they were injected with gas bubble, developed retinal tears and retinal detachment. That's way too high a risk. So the study was abandoned and closed. So at this point, using gas bubble for vitromacular traction in the office or stage 2 macular hole is probably not the standard of care, although you will see some papers on that. Mother of all vitromacular traction syndrome, this patient I saw, she had severe vitromacular traction with macular cyst, epiretinal membrane, significant subretinal fluid. And as I said before, when photoreceptors are under stress, you see this white line. You don't see the two segments of the photoreceptors. So these photoreceptors are under stress. And after vitrectomy and membrane peel and gas injection, this patient has enjoyed good visual improvement and anatomical stabilization. These are some of the stages of macular hole, stage 1A and 1B, stage 2. Stage 1 and 1B is usually not treated because 50% get better on their own, but anything stage 2 or more usually requires surgery. And these patients need to be operated because if you leave them alone, the natural history of macular hole is usually progressive enlargement of the macular hole and loss of central vision. And there is a time, if you go more than 6 months to a year, the visual improvement is not as robust. So timing is very important in these patients. This is a patient I saw in my office, and you saw that he had a stage 2 macular hole, and vitrectomy and membrane peel and gas was done. Sometimes, I do not usually aggressively do any type of dissection around the hole or aspiration. So a lot of time my patient will have a small cyst afterwards. It's okay. As long as there's a roof over that cyst, the hole is closed. This time will take care of it. It's better not to touch too many things around the fovea because the patient is going to see through it. And this is a patient who came in with a vitromacular traction I showed you before. Over time, as the vitromacular traction resolved, he developed a full thickness macular hole. And initially I observed him, but it did not close. So we did a vitrectomy and membrane peel, and the hole closed with significant visual improvement. This is a patient with epiretinal membrane with a lamellar hole. Again, this is different from a full thickness macular hole. Epiretinal membrane with a lamellar hole, you only treat it if the vision is worse than 20/50 or they are very symptomatic. If they are older patients and they're happy with their vision, you can just watch these patients also. This is a classic epiretinal membrane with a lot of what we call retinoschisis of the nerve fiber layer and rupture of the ILM rupture or ILM tears with prolapse of the tissue. And majority of macular puckers do not progress over time, and only 15% will progress. And if you do surgery, you can get good results. So this is another patient with an epiretinal membrane with a lamellar hole. This is another patient with an epiretinal membrane. Now, this is very important. This is a patient with an epiretinal membrane, high myop, so you can see the posterior cephaloma. It's kind of very deep looking macula and had an epiretinal membrane. You remove the epiretinal membrane, but look at this. It's smooth. His vision got better by 50%, but when you do the OCT, it looks like there's still macular edema. When you do epiretinal membrane surgery, the macula never goes back to normal unless it was intervened very early. So you always look like there is thickening in the macula. Majority of the time, it's just internal disorganization of the macula, and it does not get worse. So this patient is good anatomic outcome. Nothing else needs to be done. He doesn't need to be treated for macular edema. Another patient had epiretinal membrane with macular schisis. You see these, the retina is almost macula is being split a little bit. You do the vitrectomy and flatten it, it looks pretty good. And this is a patient who you may see high myope, has peripapillary atrophy, and then suddenly you see this yellowish lesion. The eye does not see what the mind is not thinking of. After seeing these pictures, when you go back to your clinic and start seeing these high myopes, these glaucoma patients, start monitoring, you'll start to see this stuff, this yellow stuff. This is called peripapillary intrachoroidal cavitation, ICC. It's not a mass, it's not a tumor. If you do an OCT, basically it's a cavitation through the choroid, okay? And it's a normal thing present in high myopes, very common, and nothing needs to be done for it. This is a patient suddenly presenting with loss of vision. You can see that the right eye is normal. Left eye has a cherry red spot right there and has papillomacular bundle is intact. So this patient has central retinal artery occlusion with sparing of the ciliary retinal artery. And then has, so this takes up to 6 hours. So if you see a patient quickly, like within an hour, you're not going to see the fundus will look normal. However, and the fluorescein may look normal. However, if you do the OCT, this is the same patient. This is the right eye. You can see the epiretinal membrane. Look at the left eye. There is hyper-reflectivity of the inner retina. All the inner layers are opacified. You have lost all these layers. And then the outer retina looks very dark. This is very pathogenomic of ischemia and very helpful in early central retinal artery occlusion patients. The outer retina is okay. It's just that the light is being reflected off of the inner retina. That's why it looks like this. And basically these patients, this is important. Nowadays, if you have a patient with certain CRAO or BRAO, those patients need to go to the emergency room for a stroke protocol because 30 to 40% of them either already have a central stroke or will get a stroke within the next 30 days. Also, you want to rule out giant cell arteritis. Very important. CRVO with macular edema, again, they have usually painless loss of vision. And if you do an optos or fundus, you see these hemorrhages everywhere. And when you do the OCT, you will see significant macular edema in the center in most cases. And if the blood flow is good, it's called perfused or non-ischemic central retinal vein occlusion. Or if it is ischemic, then you will actually see not only macular edema, but the inner retina will look like a CRAO. And it's not always combined CRAO. It's really just severe ischemic CRVO. Sometimes you see these lesions in the middle of the retina. It's called PAM or paramacular retinopathy, and it's been described with different conditions, but it's been described with CRVO also. And then hemiretinal vein occlusion or branch retinal vein occlusion are different grades of vein occlusion. They're all very similar. BRV, the smaller the vein occlusion, the better the prognosis. So BRVO has the best prognosis, CRVO has the worst prognosis. With intraocular injections, it's very important to because you share these patients with us. These patients, almost 30% of these patients will continue to require injections 3-4 years down the road also. So, and even if they're not getting injection, they need to be observed because they can have recurrences. And the SCORE2 results showed that. We were part of the SCORE2 that many of these patients, even at year 4, were getting treatment because they had recurrent macular edema. So, sorry, I'm getting an emergency call. So chronic CSR is another condition. You can actually, see a lot of these patients with neurosensory fluid. This is more chronic CSR. And sometimes you see fluid within the macula also, and they have recurrent attacks. And usually when you do a fluorescein, you see diffuse leakage. This is the more chronic CSR patients. And acute CSR, you see pinpoint areas of hyperfluorescence. This is basically talk about macular degeneration, which you see a lot. And as you know, within drusen's, we talk about small, intermediate, and large. So not all drusen's are abnormal. In the Baltimore Eye Survey, it showed that 83% of people above 63 years of age had 1 or 2 hard drusen's or small drusen's. So not everyone needs to be on vitamins and stuff. They have to have a certain amount of drusen's to get be called macular degeneration. Now, what do you see on OCT? On OCT, sometimes you just see these bumps, which are the drusen's. However, in patients who get progressive geographic atrophy, you will see on autofluorescence sincere, like significant black areas where the cells have been lost. And also the inner, you lose what's happening? The outer retina is being lost. And so as you go through an OCT through that area, you will see increased transmissibility of the scanning, the rays. So that there's nothing wrong here. It's just that there's nothing blocking. There's a lot of loss of tissue. So you see a lot of this thing. So this is where the photoreceptors are, and they're lost. And you can see that these layers were coming, and then boom, there's a dip. That's where you have geographic atrophy. And nowadays they talk about C-RORA or incomplete or I-RORA. Basically, it is when you have chicken or egg, which comes first, RPE loss or photoreceptors. Anyway, we know that both the RPE and the photoreceptors are lost in these patients. If there's complete loss, you call C-RORA. And nowadays, a lot of places and a lot of studies, OCT is being used to grade the degree of geographic atrophy and monitor response of certain treatments. Choroidal neovascular membrane or wet macular degeneration, there are really three types of bleeding which occur. One is type 1 under the RPE, so it's deep, the most common type, and also polypoidal is type 1 also. Now, if it goes through the Brooks membrane and goes subretinally, like a classic membrane, that will be called a type 2 membrane. So type 1 is usually the occult membrane, sub-RPE, and then type 2. And then type 3 is the RAP or retinal angiomatous proliferation, in which you see this intraretinal and subretinal fluid and hard exudates. And they're all wet macular degenerations, but they're different types and they respond differently to the treatments we do. So on the OCT, sometimes you will do a scan and you see this area that you're coming, and then boom, there's a little bit of elevation. That's called a double layer sign, a double layer sign. When you see a double layer sign, that means that there is more than likely early wet macular degeneration here. And these patients need to be observed. They don't need to be necessarily treated, but observed. This is a patient I've watched, right eye, left eye, and both eyes had the double layer sign. And you can see that right there. And now he was observed over the left eye. I never treated the left eye, and over time, it essentially collapsed and resolved. However, the right eye over time progressively got worse. He got subretinal fluid and needed treatment, and also had an epiretinal membrane also. This is another patient came in, right eye was this, left eye had this double layer sign. I didn't treat her, but I brought her back 4 weeks later, and boom, she started developing intraretinal edema, same eye, left eye before, 4 weeks later, I think 114, then yeah, exactly 4 weeks later had macular edema. So these are very important OCT signs which you can watch for. In terms of patients with wet macular degeneration, they can have sudden subretinal hemorrhage. In general, when somebody presents with a large subretinal hemorrhage with macular degeneration, they usually have what we call an RPE tear. So you do an OCT, you see a pigment epithelial detachment, and you see some blood around here. And if you keep going, you start treating them with anti-VEGF therapy, and it starts to collapse. A lot of time it collapses and the blood goes away and the PED solidifies. That's a good sign. You don't want this PED to disappear, because a lot of time when the PED disappears, you lose RPE and atrophy develops. So best is it kind of collapses, but not collapses completely. This is a patient who is being treated for RAP lesion, type 3 membrane with injections, was doing well. And then boom, this is focal area hemorrhage being treated. And these are different stages of RAP. And sometimes they start like this, and then they go deeper and they develop subretinal fluid. And this is what was happening here. I was treating her, she was doing well, and boom, she started to get up stage 3, PD developing. This is despite monthly injections of Eylea. And then one day she came in with a little bit more distortion, and you can see that she has developed this area of RPE tear. You can see this RPE right there coming, and boom, there's no RPE there, there's RPE tear. that corresponds to this area. Very important to notice that these are patients who usually present with a sudden hemorrhage. She was lucky that she didn't have that. But with aggressive treatment, you can stabilize. Then the other thing is RAP. RAP is very important because RAP patients, within 60% of them will develop RAP in the left eye, the other eye, within 18 months. So these patients are very high risk in general. The other thing is, as you're treating these patients, they start to get what's called geographic atrophy. It is really not geographic atrophy. It's called RPE atrophy. And you can see that in this patient, after like 7 years of anti-VEGF therapy, is starting to develop RPE atrophy. So we stopped her treatment to see what will happen, and boom, the fluid came back. And then the right eye bled also. So this patient, you know, although she's getting worse with RPE atrophy with the injections, you still have to treat the wet part of the disease because otherwise she will have much faster or rapid loss of vision. It's a catch-22, and you got to pick your poison. This is a very important manifestation of AMD patients. Sometimes when they're being treated, they get these things called outer retinal tubules, in which the photoreceptors make these tubules under the retina, and they look like macular edema, but they are not. They're usually focal round tube lesions. Sometimes they could look like that, like that. Usually you can see there's a round and there's like these stuff in it, almost like a burrito. So basically what's happening is the photoreceptors get dissociated from the retina and make these tubules. This does not mean the disease is still active. This is inactive wet macular degeneration. This is typically seen with MAM. So this is not an indication for treatment or decreasing the interval for treatment. Quickly, a few different options of treatments we have, you know, the off-label Avastin, Eylea, and ranibizumab. But I mentioned before about FDA-approved drugs. So brolucizumab was Buvo is a drug which got approved 3 years ago or so. We were part of the trial. And then, long and behold, some of the patients started getting inflammation to the point that some people lost vision from it. So I think Dr. Bomal was a guest speaker last night, and I think Scott Walter is also on this paper. Yeah, right there. So we pulled together our cases of this inflammation from the country and published it. So most doctors are not using Buvo, but there's some new treatments which are coming are this PDS, which will be a sustained release, and you can inject and see these patients every 6 months. And the other one is the faricimab. So there's a lot of new treatments coming. But the most important thing you can tell these patients is that these treatments need to be continued, and it's not a cure, it's a treatment. So I think I'm done. I for some reason, Ed, I can't find my question slides. So.
Well, let me tell you, this was such a great distillation of such a large amount of information. Very briefly, you know, we talked about the OCT findings. What's next on the horizon for diagnostics?
So OCTA is, the reason I did not include OCTA was because it's just, in itself is such a very aggressive, like very sort of big thing, and most people are not using OCTA in their practice. That's why I wanted to use, but OCTA is really the other, and that's, now they're talking about wide margin OCTA. So with the newer technologies, I think sooner than later, we will replace fluorescein, classic fluorescein, with this OCTA technology.
It's a very exciting time in retina. We have lots of treatments and diagnostics advancements that are out there. So it'd be interesting to look into the future. Thank you, Dr. Chowdhury, for your time this afternoon. Go answer that emergency call.
Thanks a lot. Thank you.
Have a wonderful afternoon.
You too.
All right, so that'll take us to our next speaker, Amy Mehta. She comes to us from New York. She's glaucoma fellowship trained at Illinois Eye and Ear Infirmary. She serves on the board of the New York State Ophthalmologic Society, and she serves on committees for the American Glaucoma Society. And she takes her time when she's not in practice teaching the residents at New York Eye and Ear Infirmary. If your doc ever comes back from the operating room and they're in a bad mood, it may be because they have experienced something like what she's going to talk about, and that is complications of cataract surgery as well as of MIG surgery and the treatment options for these complications. She's going to speak about this in her talk titled Complications of Cataract and MIGS, or Minimally Invasive Glaucoma Surgery. Welcome, Dr. Mehta, and thank you for joining us from New York.
All right. Thank you so much for having me. You can hear me?
Yes.
Yes. Okay. Well, it's great to be here, and I think this is such a great venue for technicians not only to get credit, but also to learn about things that they participate and see and take care of patients with every day. Cataract surgery is the most common type of surgery that's done in the US, not only just eye surgery wise, but in all types of surgery. It's 4 million surgeries are done a year in the US, 28 million a year worldwide. These numbers are from 2020 and projected to go up to about 6 million per year in 2025. So lots of people get cataract surgery. Most patients in the US, 90 to 98% of them have successful cataract surgery, are happy, see better, and don't have any complications. These patients are typically the patients that don't have underlying risk factors for complications. So really the goal of not only this talk, but in general in our clinics and in our practice is reducing the number of complications that we see. The way we can do this is better identification pre-surgery of risk factors and more timely diagnosis and treatment of post-surgical issues. I wanted to get out of my talk for a second. I wanted to just share briefly a surgical video by Ike Ahmed of just a quick cataract surgery. I'm not sure how many technicians have been in the operating room with their doctors while they're doing cataract surgery, but here are just some basic steps. The surgeon just made a small incision in the cornea and injected some jelly, which we call viscoelastic. He then made a main cataract incision in the cornea and is now making a circular what we call a capsulorhexis is the opening in the top of the cataract and the onion skin, the capsule of the cataract, to then be able to reach in and remove the cataract. This part of the procedure is very delicate, as are all the steps, probably the most important though. Here the surgeon is creating a water plane with that instrument between the onion skin of the cataract and the cataract itself, kind of trying to separate the cataract from the bag in which it sits. Next, this larger instrument is the vacuum that basically eats up the cataract, and the other instrument helps to break it apart. So you can see here he's breaking the cataract into smaller pieces that are easier to eat. And I think it's important to see this kind of surgery, maybe watch videos. It helps you as a technician better understand, what it is the patient went through during the surgery. Here they're just removing all the different pieces of the cataract, but leaving the bag or the onion skin of the cataract in place. And then they kind of switch out the big instrument for a little bit of a smaller one to help remove all the cortex, which is like a membrane that sits between the capsule and the cataract. And once they've delicately removed all of this, and of course he makes this look very easy and quick. Typically surgery is not just 3 or 4 minutes. They're injecting more jelly into the eye because we don't want the eye to collapse. And here he's placing the intraocular lens in the capsular bag in the onion skin of the cataract. Very important here at the end, they remove all the jelly, the viscoelastic from the eye, and inject just some BSS or saline to help close all the wounds of the cornea. So the reason I wanted to show you that video, very straightforward surgery, is because cataract surgery can be done like that, very simple. The lens is in the bag and everything goes as planned. But what about those patients where it doesn't go as planned, and what can happen after that? So I've kind of listed here some early complications that can happen from the first post-operative day 1 onwards. Things like a wound leak, high pressure in the eye, some of the cataract wasn't removed completely, allergies to medications. And I've also listed here some later complications that we'll go through. You can see that there's a little bit of an overlap between early and late complications, as some complications can happen pretty much throughout the entire post-operative course of the cataract surgery. Most importantly, the first thing that you look for when a patient comes in on their first day after surgery that can happen is a wound leak. A wound leak can happen in, surprisingly, about 1/3 of wounds that are created. You saw at the end of that case, he injected saline into the wounds to help hydrate them and help them seal on their own, typically without a stitch being placed. Well, these wounds have to self-heal over time, and a lot of times the first day after surgery, they can leak. The prognosis is typically good if caught. You can treat it, and they usually heal. The patients will come in complaining of potentially tearing, decreased vision, light sensitivity. Ways that you can identify it as a technician is if you are the technician who's taking either a tonopen pressure or a Goldmann applanation pressure, the pressure might be low, maybe under 8, because the cornea and the anterior chamber are leaking aqueous fluid. You might notice that the patient has a shallow anterior chamber. There may be more corneal edema or corneal folds because everything's kind of squished. There isn't enough pressure in the eye. As a technician, very important to obtain a detailed history, check vision, potentially check pressure if that's okay with the doctor you're working with. And the doctor is going to check an important sign that will help with identifying a wound leak, which is checking a Seidel. Seidel positivity, as you can see over here, is when you notice the aqueous fluid is leaking out of the eye. You check it with one of these fluorescein strips and a drop of proparacaine. You just sweep it over the wounds to check if there's a wound leak. It can be mild, just a pinpoint or a little bit of a droplets coming out. It can be moderate where the anterior chamber is still formed, but there is an obvious leak. This can be treated sometimes with a bandage contact lens, topical antibiotics. You don't want an infection from the open wound, and possibly glaucoma eye drops to help decrease the amount of aqueous that is secreting from the eye. If this leak is very severe, the surgeon might opt to put in a stitch to help keep the wound closed and help it heal faster. The next, also pretty common complication after cataract surgery is ocular hypertension, high pressure in the eye. This can happen, as you could see from the surgery, you're injecting a lot of jelly or viscoelastic into the eye, and if not all of it is removed at the time of surgery, some of it can be retained in the eye and it can clog the natural drainage system or the trabecular meshwork of the eye, leading to high pressure on day 1. Further on, later in the post-operative time period, weeks or even a month or 2 down the line, it may be that the high pressure is from a late steroid response. Most patients are kept on some type of either prednisolone or steroid eye drop after surgery. And some patients are more prone to having an IOP spike with this with these medications. In any case, if as the technician, the symptoms to look out for on your detailed history include periorbital pain. That's a very big sign of high eye pressure, redness, tearing, potentially decreased vision, light sensitivity. On the exam, the surgeon may notice that there is microcystic edema. That in the top picture, you can see here these little bubbles that form in the top layer of the cornea. This is called microcystic because there are tiny little cysts that form from the high pressure. And obviously a high IOP on exam. The main treatment for this is lowering the pressure with glaucoma drops, potentially Diamox pills. And if the pressure is very high and you can see a large glob of viscoelastic, the surgeon may, opt to press on the lower lip of the main wound and burp out some of that jelly. Another complication that can happen pretty early on in the post-surgical course of cataract surgery is having a retained piece of the cataract in the eye. It's not a very high percentage, less than 1% of patients who have cataract surgery have this occurrence. And prognosis can typically be good if identified, you see the piece, you know it's there, and you treat it right away. The patient probably will have more inflammation in that area of the eye where the piece is sitting. Finding the piece is very important. So looking specifically for localized corneal edema or inflammation in the eye. Sometimes the patients may have very high pressure due to this inflammation. They may have tearing, light sensitivity, pain. Taking a good detailed history, checking vision, checking pressure. The surgeon will probably look to do a gonioscopy to check all the angles to make sure there aren't any other additional pieces hiding out in any of the angle. Sometimes if the piece is very small, a longer course of steroids or NSAIDs to decrease the inflammation and to kind of help that piece break apart may be used. Sometimes for the high pressure, patients may have to be put on glaucoma eye drops. And eventually, a week or two or, a few weeks later, if the piece does not look like it's getting any smaller or disappearing, the surgeon may need to take the patient back to the operating room to wash out the piece from the anterior chamber. Of course, the most dreaded cataract complication that can happen anywhere from 2 or 3 days after surgery to weeks, months, or even years later after cataract surgery is endophthalmitis, an infection, severe infection of intraocularly in the eye. Luckily, the percentage of patients that develop this is about 1% or less. Very, very important as a technician. You're the first line of patient talks to, tells all of their, regimen. Are they using their drops properly? Did they take a shower? Did they go swimming, get water in their eye? Any signs that they could have gotten an infection, very important to, get that history. But the patient will typically come in with pain, potentially floaters, redness, and severely decreased vision. On exam, they'll have inflammation, significant inflammation in the front of the eye and the back of the eye. And specifically, we look for this little layered white cell formation called a hypopyon that sits inside the anterior chamber. The surgeon will want pressure and vision checked and a dilated eye exam, getting imaging like a B scan to check for inflammation posteriorly, potentially a retinal detachment, getting any type of photos and OCT of the macula. And this complication requires urgent retina consult with tap and inject of antibiotics. And essentially daily follow-up, and potentially this patient is looking at going back to the operating room with the retina surgeon for a washout PPV. So yeah, it's a very poor prognosis, but if caught early on the day that it starts or the next morning, and given the right antibiotics intravitreally, patients can recover. This is a very common post-surgical complication. Here I've written an incidence of 0.47, which is those patients that persist with corneal edema. Here you can see a picture on the right of this corneal band of light and the bottom edge being frayed. You can see a significant amount of corneal edema. Patients that are more predisposed to persistent corneal edema are those with a condition called Fuchs, or like we mentioned before, if you have a piece of cataract that remained retained in the anterior chamber, that can result in persistent corneal edema. Prognosis can be good if treated early. Patients will present with decreased vision, light sensitivity, typically a lot of glare. They may have low pressure or high pressure. And the very important thing to do is getting a detailed history, checking for inflammation, potentially a dilated eye exam to make sure there's no retinal inflammation that could be resulting in the corneal inflammation, and putting the patient on a longer steroid taper. Rebound iritis is also unfortunately common. It can happen in about 1% of patients. As it is rebounding, that means it's a late time frame. The patient has already been tapered slowly off of the inflammatory eye drops, steroids, and NSAIDs. They've already been tapered off of them, and they come in with a inflamed eye with anterior chamber cell and flare. They may have light sensitivity, pain, redness, decreased vision. They may have low pressure in their eyes, but very importantly, they don't have signs of infection like a hypopyon. Getting a detailed history. Did this inflammation start right after you finished your course of steroids? Do you have a history of uveitis or any other type of inflammatory condition? The patient will typically need to be dilated, get a B scan, check for anterior chamber cell and flare. And the treatment is typically restarting their steroids at a longer, slower taper of their steroids over time. This complication can be a little bit upsetting, frustrating, especially for how much work that's taken to pick which intraocular lens goes in the eye pre-surgically. But some patients, the lens just isn't the right power for them. They had a toric placed, and the toric, the direction in which it was supposed to be sitting has rotated into the wrong axis, or the lens itself has dislocated from its position, as you can see in these two photos here on the right. These issues can happen to up to 3% of patients, and the poor prognosis can be poor if these things cannot be addressed. As the lens is out of position, the patients can come in with either like a crescent in their vision where that gap is between the lens and the iris. They may have more glare, decreased vision. They may even notice that portion of their visual field is cut. On exam, of course, you find that the lens has dislocated out of its position. It may be wobbly. And when dilated, you can appreciate potentially that the toric lens is not in the axis that it had been intended for. Getting a detailed history, the surgeon may choose to repeat the IOL calculations, dilate the patient, and potentially, given what they see on exam, they may opt to surgically reposition or suture the lens, or maybe even replace the intraocular lens with a new lens. And this kind of complication can really guide the surgeon, if this is the first eye, as to what how to approach the second eye for surgery to avoid these similar complications. Another very dreaded and unfortunate complication that can happen after cataract surgery, typically in those patients who are very nearsighted or myopic or have a family history of a retinal detachment, is retinal detachment. It can be severe, and it can even happen months to years after the cataract surgery. The number one thing that patients come in when they have a retinal detachment complaining of is flashes of light or a curtain coming down over their vision, decreased vision, floaters, things that you look for on exam. You find a decreased vision, potentially a visual field cut. The surgeon may find on a dilated exam a retinal detachment, a large hole or tear in the retina. Getting a B scan, an OCT of the macula, potentially fundus photography, and of course, an urgent retinal consult. They may opt to do laser, gas fill, or even take the patient to surgery, depending on the type of retinal detachment. Another early or potentially even late complication is cystic macular edema. Here you see on the right these little flower-like pattern, petaloid pattern of a flower, and an OCT here showing these little cystic or little purse-like bubbles of fluid. Cystic macular edema can really happen in any cataract patient, but those who are more susceptible to them are the people who have pre-existing retinal problems like diabetic retinopathy, or sometimes even patients with macular degeneration, although if controlled for both of those, it typically doesn't happen. The longer that it stays in the eye without being treated, the worse off the patient is. Their retina can undergo severe damage, but if treated aggressively from the beginning, the prognosis can be good. Patient may present with distorted vision, like wavy vision, like something you would teach them to do an Amsler grid for. Signs may be a decreased vision and obviously macular edema on exam. Getting an OCT of the macula, potentially an Optos photo, and patients who are treated for this are treated with steroid eye drops, as well as particularly NSAID eye drops. Sometimes they even need an injection of steroid medication by a retina specialist. And the most common complication after cataract surgery, which is still considered a complication, but a extremely commonly treated one, is posterior capsular opacity. It's up to 50% of patients can experience posterior capsular opacity. It's basically scar tissue or a membrane that the back of the bag or the onion skin is the posterior capsule, and it kind of scars. There are little cells of the capsular cataract that kind of grow into the center there, and you can see here that in the center of their vision, and here without the red reflex, you can really see the way that it would impact somebody's vision. Prognosis is very good because we have a way to treat it. Patients will present with decreased vision and glare and halos, maybe up to months to years after the cataract surgery. Getting a detailed history, checking vision, refracting the patient, and the surgeon most likely will discuss the risks and benefits of doing YAB capsulotomy in office. Pretty benign procedure. Here you can see a surgeon has made a small opening in the posterior capsule where the PCO was to allow the patient to see better. And lastly, I included here just a quick complication, a hyphema. Most MIGS or minimally invasive glaucoma surgeries are combined with cataract surgery, and so their complications are the same as cataract surgery. The one that I feel is more common when you do a MIGS procedure as opposed to cataract surgery alone is a hyphema. Here you can see layered blood here at the bottom of the anterior chamber. Typically happens, you see it the first day. It's not really much to worry about. It definitely can be treated with the same eye drops that cataract surgery patients are treated with. And the surgeon will probably want to do gonioscopy to make sure either, the eye stent or the hydrus or whatever MIGS procedure they did didn't cause any severe damage and is still in the same position that they placed it in during surgery in the anterior chamber angle. But it can also lead to high pressure, which may have to be treated with glaucoma eye drops. I went through some of the red flags that you should be looking out for, but basically as a pre-surgery patient, we tend to ask things like, is the patient on Flomax? Do they have astigmatism, diabetic retinopathy? Do they have a family history of glaucoma or high myopia or retinal detachments? Do they get retinal injections? Are they on blood thinners? And as a technician, you also need to observe the patient in pre-op and post-op for things like, do they keep bending over to pick things up off the floor? Are they rubbing their eyes, or do they not remember their drops? Really, as a technician, you're the first line to the patient. They feel comfortable talking to you. They may not be as afraid to share their compliance of their drops with you, and you're the one who can notify the surgeon of any of these things if you feel like they're a red flag. But thank you for having me, and if you have any questions or anything, you can feel free to ask me or email me.
That's a great talk. Thank you so much, Dr. Mehta, for sharing your time with us. Oftentimes our technicians are the ones fielding the clinical calls and triaging patients. What are the ones you really want to make sure what questions do you really want your technicians to be asking to know, does this patient need to come in now or can they wait till next week?
Right. So the couple that I mentioned that are really the severe complications, endophthalmitis, retinal detachment, extremely high pressure in the eye. Those are kind of some things that, like flashes of lights and floaters are definitely signs of retinal detachment that you want to be asking for. Severe pain in the eye, decreased vision, a curtain coming over their vision. Those are the red flags that I would really, make sure the patient is seen that same day.
Yeah, very valuable. And thank you. I'm sure our technicians will go out there and conquer the world and save our patients for us. So it's good to have this information. Thank you so much for your time.
You're welcome. Thank you.
Our next speaker is Soshin Sarifpour. Dr. Sarifpour is glaucoma fellowship trained at Yale, but he's been quite a standout his entire career. He was graduated summa cum laude from Tufts. He was inducted into Phi Beta Kappa. He was in medical school inducted into Alpha Omega Alpha, the Honor Society. He did his residency training at NYU, and as I said, he did his glaucoma fellowship at Yale University, where he is now on faculty there. And he provides care in both the New Haven and Stratford offices. He's going to take us to OCT imaging and look at some of the scan protocols, the machines, the functionality, and review some of the common artifacts that we will see on OCT in his talk that's titled OCT Basics and Common Artifacts. Welcome, Dr. Sarifpour.
Thank you very much for the very kind introduction. It'll be hard to follow all the excellent presentations so far, but I'm lucky enough to talk about very exciting topics in OCT and glaucoma. So I have no financial disclosures. And some of the things, as mentioned, that I would that I'll be talking about is just I'll spend a few minutes talking about OCT options, different machines, different protocols, very briefly there. Then I'll go on to talk about, in particular, OCT RNFL, OCT GCL, and OCT angles, and how we use them in different settings and how visual fields may work their way in comparison based off the findings that we find with those. And then lastly, I'll spend most of my time going through some common artifacts that we may see on our OCT RNFL scans, how to identify them and how to best kind of rectify them to avoid causing problems in terms of diagnoses. So starting with the fundamentals of OCT. So OCT, kind of as mentioned in the previous talk, is effectively just an optical ultrasound. Effectively, instead of sound, we're using light, and the light's going into the eye or we're hitting whatever tissue that we want it to hit. The light interactions are occurring. It's coming back to our machine where a complex algorithm is applied and then used to generate some very pretty pictures for us. Because we're using light, the most important thing for us is needing a clear or good media. Things like cataract surgery, we know, things like cataracts, vitreous hemorrhage, dry eyes, poor ocular surface can affect the quality of our scans, which can affect the findings of our scans as well. So things like artificial tears or doing surgery and things like that may benefit in the long run. Again, so very simply kind of put, the machine has a light source. It shoots out a bunch of light. It hits a beam splitter where some of that light goes to a reference mirror in the machine itself, which the machine uses for comparison. And some of that light goes to the actual tissue where it then enters and bounces. Some of the light hits different layers of the tissue. Some bounces back, some keeps going, some bounces back, some scatters and so forth. Eventually the light works its way back to the detection unit. And in the detection unit, there's usually some machine that's applying some sort of algorithm and comparing the input from the reference mirror to generate the pictures and the thicknesses that we end up reading and showing to our patients. Very briefly, there's a couple of types of OCT machines, and many of you are probably familiar with some of them, but just a few brief words. One of the most common ones that we utilize here is the Cirrus OCT. So this is the machine illustrated below, and this is kind of the scan outputs that it puts out. The patient puts their head here and the imaging head is right here. This moves a little bit, but it's relatively immobile compared to some of the other machines that we have. As a consequence, it's usually a lot easier to use, right? You don't really have to do anything. It kind of just moves, or we can move it minimally in its own way. But, because of that, it's also a little bit more reliant on the patient. The patient has to be relatively compliant to get good scans with it. The number of scans it does is pretty quick, 27,000 per second, and it has pretty good resolution. The other thing to kind of mention about the Cirrus in particular is that some people feel that it has a little bit better of an algorithm in terms of tracing vessels and in terms of RNFL progression. So it might be a little bit more popular amongst glaucoma people. But the overarching theme between the different machines is just there's a lot of personal preference in terms of what people like to use. The Heidelberg Spectralis illustrated below, the outputs kind of put over here. The nice thing about this is that the head that takes the photos is quite mobile. So it requires a little bit more experience to use, but we can swing this around, up, down, right, left to help get images, even when the patient may not be as cooperative as we'd like them to be. This can help us get around things like exotropias, or if we want to image something in the periphery of the retina or outside of the posterior pole, we can have the patient fixate and move the machine around to get the picture. This machine also tends to have a slightly higher resolution than the other two, which makes for prettier pictures in general, and sometimes is a little bit more popular amongst our retinal colleagues. And then lastly, there's the OptiView. Again, a great machine as well, depicted below. It takes a similar number of scans, has a very good resolution, acquires real-time images, which sometimes is helpful on more inattentive or difficult patients, and has an excellent scan protocol. So ultimately, there's a lot of different types of machines out there, and personal preference ends up kind of being the most determining factor. It's also very helpful to kind of compare the same scans from the same machines to each other, as opposed to scanning somebody with a, say, Heidelberg, and then comparing it to, say, a Cirrus scan. It won't be as useful in that respect. Very briefly, the machines offer two main scan protocols, and then I'll throw in a third one that we kind of make up on our own. The default scan protocols are just 3D scans. The machine is taking a bunch of scans and putting them together, kind of like a CT scan, and piecing together a picture for us, which we can then scroll through to get a nice idea of what we're seeing. An example of this is the macular 512 by 128, or the optic disc cube 200 by 200. The numbers, so in the 512 by 128, it's effectively taking 512 location scans along the x-axis, about 6 millimeters apart, and then 128 location scans along the y-axis, 6 millimeters apart, repeating the scan a couple of times and then piecing it together. So it takes some time to do it, but it comes up with very pretty kind of holistic images for us to scroll through. 2D is the other one, and it's much, much quicker. Effectively, we're focusing all our efforts onto one particular area. So either a particular line or a particular circle, and it's doing hundreds and thousands of scans through that same spot to get a very high signal strength to give us a very, very nice picture. This is helpful in patients who are extremely inattentive, or in patients where for whatever reason, the media is highly limited. There might be a vitreous hemorrhage and we're just trying to get some idea. By repeating it multiple times, we have some potential to see something in the posterior pole. And then the combination is the 2.5 dimension scan. And this is effectively just a way of us utilizing several two-dimensional scans and putting them together to get a little bit of three-dimensionality out of it. The classic example is the 5-line raster scan. So here we have effectively 5 lines, and each is effectively just a two-dimensional scan. It's scanning a bunch of times at each of these lines, but when we scroll through it, we get some idea of how things look overall in the retina. Now, in terms of interpreting a scan, there's a lot of factors that go in. It's not just the straightforward, oh, okay, the machine is generating green numbers for us, the patient doesn't have glaucoma, or the machine is generating red numbers for us, the patient probably has glaucoma. The machine has its own normative database that it compares to give us these numbers, but a lot of things are assumed by the machine that may not be the case in our particular patient or population, right? Each patient's a little bit different, and each scan is a little bit different. So first and foremost, signal strength is very, very important. So this is a Cirrus scan. You want a pretty good signal strength. You want ideally greater than 8 out of 10, but sometimes it can be a little bit difficult, but you want at least some 6 out of 10 scan quality there. And in terms of Heidelberg, most people want at least a 15 to 20 in terms of the signal strength. We know, and there's been many studies that have shown that as the signal strength goes down, the retinal nerve fiber layer thicknesses go down. And sometimes this can be misinterpreted as progression of glaucoma or the existence of glaucoma. And we may create treatment algorithm differences as a consequence of that. But we have to be aware of comparing the signal strength. Different things can cause the RNFL to be thicker in certain populations for our measurements and be thinner in certain populations for our measurements. So if someone is hyperopic or has a smaller eye, or if somebody has a larger disc, these patients tend to have thicker RNFLs than the average patient that might be compared to in the normative database. Conversely, if someone has a lot of myopia or a long axial length, we know these patients tend to have thinner RNFL. And in fact, the patients with high myopia may lose RNFL faster with time. We know that as we get older, nerves in general kind of fade, and the RNFL is not particularly special. So as we get older, the RNFL declines at a normal rate. And certain diseases can sometimes be associated with thinning of the RNFL. So Alzheimer's, Parkinson's, and things like that have been shown to be associated with thinner RNFLs. So all of this, when we're seeing the patient, we do want to gather this information so that when we're doing our imaging, we have an appropriate idea of how we're comparing to the normal database. Again, going back, so the RNFL from the perspective, all our machines are kind of geared towards glaucoma as opposed to neuro-ophthalmology. And from the perspective of glaucoma, the most important parts tend to be the superior nasal and inferior parts. This is where we oftentimes see progression. So when we're doing, fortunately for us, the machine splits the scan, as we're going from a circle to a straight line, it splits it at the temporal aspect. This is to the detriment of neuro-ophthalmology because temporal aspect is a little bit more important there. But as a glaucoma specialist, I'm delighted with this. So effectively, what we're seeing when we're doing our scan, we're starting right here at the temporal aspect, and this one corresponds to what we're seeing on our aspect once it's rolled out. It's going up to the superior part, right, which will correspond to somewhere around here. Then to the nasal part, the nasal disc rim will be the thicknesses that we're seeing here, the inferior part here, and then way over here where the 2 is, the second half of the temple. And this is useful to know because when we're looking for different artifacts, we want to know which part that the artifact may be affecting. A quick word about the guided progression analysis. So all the machines have the ability to look at a couple of different scans and to see if there's any progression as dictated by the machine itself. This requires 3 scans, 2 that are baselines. Typically, the first 2 scans are on the patient, so we can assign it to be anything we want. Depending on if a patient has a lot of progression at some point, they may have a new baseline, so we can change that number. Similar to the visual field GPA, this machine kind of looks and compares the numbers of the current scan to the initial baseline. And if it notes a notable amount of decline, it flags it as, orange, yellow, possible decline. And if it notes it twice in a row, it flags it as red, very concerning for decline. The nice thing about the guided progression analysis is it does take age into effect. So I mentioned that with older age, we expect a natural decline of retinal nerve fiber layer thickness. This takes it into effect. So if it's flagging something as red, it's not because the patient is just getting older and losing nerves at the normal rate. It's because it's losing nerves at an abnormally higher rate than expected. So that was the retinal nerve fiber layer scans. So we know that the retinal nerve fiber layer is the axons of the ganglion cells, and the ganglion cells are being affected by glaucoma. The retinal nerve fiber layer scans are done at the level of the optic nerve, but sometimes patients have pathology at the optic nerve or just things that can, physiologic changes that may cause their scans to be less accurate. Things like peripapillar atrophy, myelinated nerve fiber layers. Tractional membranes that might be present or whatever. Those may cause us to get less accurate results with our retinal nerve fiber layers. So fortunately, we have a ganglion cell analysis. And we're lucky in that over 50% of the ganglion cells are located in the macula. So if we scan the macula, we can get an idea of the amount of ganglion cells that are present and how it's doing compared to the normal population, whether damage is happening or not. Again, as mentioned, this is useful in patients that have peripapillar atrophy, peripapillar disease, but normal macula scans. The other nice thing about the ganglion cell analysis is that because we're looking at the macula, we're looking at the central vision. And central vision is generally much more significant to patients than peripheral vision, right? If something damages someone's peripheral vision, people may not notice, but if something damages someone's central vision, people are very sad about that. So we know that studies have shown that the ganglion cell analysis actually correlates a little bit better with 10-2 visual field findings and can catch things that are sometimes missed on RNFL, especially in the central field loss. Similarly, if someone has macular disease like a giant macular scar or geographic atrophy, the ganglion cell analysis won't be as useful. And in those patients, we need to do retinal nerve fiber layer analysis. So, I won't bore anybody with any particular studies, but, literature reviews have been done and show that the RNFL and GCL are pretty close. Maybe the RNFL is a little bit better, so we use it a little bit more frequently, but it's very, very close, and both are useful in different situations. So you'll see us oftentimes order both and kind of monitor both. The other thing that's kind of interesting, so every test that we do, including the OCT, has a maximum amount of damage that it can identify. And this is called the floor effect. So at a certain point, so much damage will have happened to the nerves that even though nerves are present, the machine won't be able to tell how much nerve is present. It'll just kind of overlap and detect it as effectively 0 nerve left, even if it's not there. That level is the floor effect. That's the maximum measurable damage detected by the machine. So for RNFL, the floor effect is somewhere in the 40 to 50 micron range in terms of average. And it's a different floor for each segmental area. GCL has a slightly lower floor, so it might be a little bit more useful in patients with a little bit more advanced glaucoma. So GCL being in the 30 to 40 micron range. However, eventually, especially in very advanced glaucomas, the floor is reached in both of these. In those situations, it might be more useful to track patients with visual fields because visual fields, one, are functional, and as long as visual fields have their own limitations as well. They're very difficult, they're very boring, they take a long time. But if the patient is able to do it, we can get some idea of if progression is happening in more advanced glaucomas. And visual fields are also functional tests as opposed to structural tests. So OCT is just looking at the thickness of the nerves. It's not telling us how this is affecting the patient, whereas visual fields are telling us, like patients are missing XY amount of vision. And they can help us in situations where the OCT may come up as falsely full or something of that nature, looking for other etiologies as well instead of just glaucoma. So the nice thing again about OCT is that we've seen in many studies that OCT progression predicts visual field progression. So damage, if it happens on the OCT, eventually will lead to damage on the visual fields. Effectively, we have tools that can find damage before actual vision loss occurs, which is nice. So in short, OCT is objective data, which is nice, and it's a structural test. So we're looking at the structural changes. It is not a functional test again. So whatever we see on OCT doesn't necessarily correlate with actual loss of vision at that particular time. It may in the future, but it's not telling us how this is affecting the patients as opposed to visual field, which does. There are, it's nice in that we can pick up disease early, maybe even before patients are symptomatic, but it can be affected by a lot of different things, including artifacts, including different medications and diseases and things like that. And the floor effect does limit it eventually. So visual field plays a role in more advanced glaucomas. A few brief words just about OCT angles. So we're fortunate, we've learned that if we readjust the wavelengths, we can use the OCT machine to scan the anterior segment of the eye instead of the posterior segment of the eye. And this is really helpful for a couple of different things, including looking at corneas and things like that. But from the glaucoma perspective, it's great at looking at angles. If we scan the patient in the dark when they're most susceptible to being having the narrowest angles, we can get an idea as to whether they have closed angles or not. And studies have shown that if we see closed angles on OCT angles, it's probably, it's pretty specific. It doesn't necessarily rule out narrow angles. So we still have to do things like gonioscopy and or ultrasound biomicroscopy if we're suspicious. But if we see it, it does really help ruling it in. It's non-contact, it's relatively quick. And the really nice thing about it is that it really helps in terms of talking to patients because we have pictures to show them. And we can show them their angles and we can show them normal angles and we can show them how at risk they are. And this can kind of help them make educated decisions about their treatment plan. It does have a limited ability to visualize super far back. So oftentimes with OCT angles, we may not necessarily see the ciliary bodies as clearly, and we may not get a good view for ciliary body tumors or choroidal tumors or things like that. And ultrasound biomicroscopy may be better if there's suspicion in that respect. Plus the machine is different, the algorithm is different, it may cost extra and it may not be accessible to everybody, but something nice that we have. When we're doing the scan, effectively, if I'm looking for narrow angles, I'm looking at this particular part, right? I'm looking to see where the hyperechoic portion intersects with the darker portion, the ciliary body and the scleral spur outline. And then I'm looking to see if the drainage system is open at that particular intersection. Some people find that if you create a line through the cornea and a line through the iris, it creates an angle. And we know that sometimes if the angle is smaller, they're at higher risk. So if someone has an angle that's say less than around 20 degrees, it might induce us to worry about these patients a little bit more and to at least follow them and monitor them with OCTs and or gonioscopies. So now the most exciting part of the talk. So I'll go through some different artifacts. I left the answers blank and I'll kind of show them as I go through, but I'll encourage people to think about what the artifact might be in each of these and what to do in case it once identified. So here, the machine, as I mentioned, effectively is scanning through the optic nerve, right, and creating a path and deciding where the retinal nerve fiber layer is and then tracking it, and then measuring the thickness in between to create these numbers for us. Here we can see the machine does okay in the posterior aspect. It's not perfect. It's a little off right here. It's a little off right here and so forth, but it's okay in the posterior axis. But if we look at the anterior aspect, right, we can see that it mistracks. There's a little fibrous band that's pulling. And here we have an anterior acquisition artifact. It's mistracking and measuring that band instead of the actual retinal nerve layer. As a consequence, when we look down here at the nasal portion, we see a huge amount of thickening, which is clear artifact. Similarly, so in this machine, we can see the signal strength is a little bit weaker, right? It's a little bit more grainy. The anterior aspect here, the anterior acquisition is pretty good. It's actually almost spot on. However, when we look at the posterior aspect, I may miss something there, but over here, it completely misses the posterior border of the retinal nerve fiber layer and instead jumps to the anterior border. So this is a posterior acquisition defect. And of course, it's measuring this as 0. So it's going to measure the nasal aspect that's completely thin, and effectively it's flagging that area for us when in fact it may not necessarily be thin, it's just being misread. The nice thing about the Heidelberg is that it does give us the option of kind of readjusting the machine's acquisition points. So you'll see sometimes when I see something like this, if the patient's already gone and we can't rescan them, if you go to I'll go to this button right here and it'll give us dots highlighting the areas that are being tracked. And we can adjust those dots to the appropriate border to get a more accurate representation and to effectively fix the error. So something to bear in mind in that respect. I'll say here, the OCT, as I mentioned, takes the numbers that it's seeing and compares them to the normative database. And I've said that this is a problem because the normative database may not reflect the population we're seeing, either by race or by gender or by the visual, the axial length and so forth. One other thing that the machine assumes is that we're doing perfect scans each time. So it's assuming that everything is 100% perfectly centered. We know that as the nerves, the distance of the retinal nerve, the distance of the nerve to the optic nerve matters in terms of how thick that area is. So here we can see that this optic nerve is shifted off to the side. It should be perfectly centered. Unfortunately, what happens is because now what's happening is the machine can't tell that it's necessarily decentered. It's kind of assuming that it's relatively well centered. It's going to compare the portions of the nerves that are here to what it assumes should be here, right? The machine is assuming that the optic nerve is right here and that this nerve right here would be the equivalent of what we're seeing here. And as a consequence, it's no longer comparing apples to apples, it's miscomparing to its normative database, and that can give us some misreadings in that respect. So getting a good centered image is very important as well. Sometimes, so here we have a little bit of an outline artifact. We can see it's kind of tracking pretty well right here, right? But right here, something happened. Either the machine misscanned or something got in the way very briefly, or there's a shadowing artifact from something or whatever. Something happened and we're missing a little portion here. And this completely messes up the machine in terms of analysis right here, right? It's tracking and then it completely collapses in terms of tracking here. We see that the difference between the right and the left eye is noticeable, right? The inferior aspect is thin and it's flagging the superior as a little bit, not necessarily thin, but as flagged, right? And that could be a consequence of what we're seeing here, because this would correlate with the supranasal area. So an outline area, effectively, it's misidentified the retinal nerve fiber layer borders. What about here? So again, the machine, I'll talk just briefly and you can kind of think about what potential artifact might be here. But effectively, the machine shows us two pictures, right? One picture here is effectively what the machine is reading in terms of the retinal nerve thicknesses. So red here means that the nerve is thicker. And this is typically what we're expecting, right? Thicknesses, as it's kind of coming out in an arcuate pattern, a little bit thinner in the other aspects. The deviation map is nice in that we can see the blood vessels and things like that. And effectively, it's comparing it to the normative database. So red in this particular area is going to be areas where it's seeing it thin compared to the normal database. If we look right here, we can see in this particular situation, the patient moved. Right, the blood vessels are no longer lined up. Here we see the blood vessels are perfect and pristine. Here, the blood vessels are not lined up. So the patient must have moved and then the scan continued at that point. Similar to the decentration artifact, This is a problem because we know that the thickness of the RNFL is again impacted by how far away it is from the optic nerve head. So if the patient's moving, the machine's not going to be comparing appropriately, and we'll end up with artifact and misreported information. What do we have here? We can see on the right side, things look pretty good. On the left side, we notice a lot of thinning. It even looks kind of like a bad scan in general, and we can see that the scan quality is lower. And as a result of the lower scan quality, the algorithm is completely messed up. It's unable to detect the retinal nerve fiber layer. This patient probably blinked, right? Which makes sense, because if the patient blinked, then the machine is scanning the eyelid, which has no retinal nerve fiber layer. So of course, it's going to come up as abnormally thin. So we just need to rescan this patient when they don't blink. So this is a little bit more of an interesting one, right? If we look, we can see a difference between the two eyes, and we know that glaucoma is oftentimes bilateral, can be unilateral, but oftentimes bilateral, but is almost always asymmetric. So asymmetry between the two eyes in terms of thicknesses is often a flag for us in terms of detecting glaucoma. Here we can see down here that infranasally is the area of particular concern. It's where it's being flagged. When I look at the maps, I can see right here, right? I see this one area in the infranasal quadrant that's coming up as black, right? It's not reading anything there. And here on the deviation map, I can see that the machine is in fact confirming that it is detecting that as an area of thinning. And that's probably the area of thinning that's causing this to turn a little bit more yellow. When I compare it to here, you can see that there's a little bit blacker here, which correlates with that same particular spot. So this patient has a floater, and the floater is blocking the scan at a particular area, which is causing us to think that maybe this patient has glaucoma, when in fact it might just be an area that's being misscanned in particular. Ways around this, you can have the patient look up, down, try to get the floater out of the way to rescan, and then have two kind of scans in terms of ability to compare, or just bearing it in mind and monitoring it in that respect. Other things, I'll go a little bit quicker in that respect, but other things to bear in mind here, we have peripapillary atrophy, which can cause thinning, and which might prompt us to do a GCL analysis instead. Here, we have a scan of the macula, unfortunately. So if we scan the macula, and so we scan the macula with an RNFL analysis, when in fact we may have wanted to do a GCL analysis. So of course, it's going to misread it and create artifact thinning in that respect. And then I think this is my second to last slide. So here we have the machine completely unable to recognize any borders here because of the myelinated nerve fiber layers. So this is a myelinated nerve fiber layer artifact. And again, both in this patient and the patient with PPA, we may be better off tracking with GCL analysis. So the big take-home message here is that so this study looked at 2,300 scans consecutively, and they found when they looked really closely, 46% of the scans that they did with very experienced photographers and technicians had artifacts. So it's really important for us to bear this in mind, because almost 1 in 2 scans may have artifacts. So in conclusion, OCT is reproducible, it's objective, and it helps a lot in terms of monitoring glaucoma and progression. But visual field 24-2s and visual field 10-2s also can help detect progression and can be really helpful in very advanced glaucomas. GCL is helpful, especially in patients with peripapillary abnormalities, but is less helpful in patients with macular pathologies. Artifacts are really common. 46% of the time we may have an artifact. And RNFL can vary in different patients. So not all patients are the same, and not all diseases are the same. It may be thicker if the nerve is bigger, or and it may be thinner in patients with Alzheimer's disease. Thank you very much.
Thank you. It's always good to get better clarity on these instruments that we touch, and we look at their outputs every day and as we manage our patients. So thank you again for spending some time with us this afternoon. Our next speaker is going to be Erin Walsh from New York. Dr. Walsh is co-director of the Pediatric Ophthalmology Service at New York Eye and Ear Infirmary of Mount Sinai. She got her medical degree and master's in physiology from New York Medical College, and did her residency at the Department of Ophthalmology at the Medical College of Georgia. She did her fellowship training in pediatric ophthalmology from the Albert Einstein College of Medicine. Today, she's going to speak with us about amblyopia and highlight why vision screening is important to detect risk factors leading to amblyopia in this very important group of patients that we're caring for. This will be done in her talk titled Protecting Children's Vision. Thank you for presenting this very important topic.
Good afternoon, everybody. You guys can hear me okay? Thank you so
Yes.
much for that introduction. Of note, and this was done in between actually signing up for this presentation. I am also new faculty now at Yale. I have joined them. I miss my colleagues down in New York dearly. I'm still faculty down there. I hope to see them at some point in the future. But yeah, I'm excited. I live in Connecticut, and so I'm excited to become a member of the society up here. And I really am thankful for being able to present on both ends up here. And I will hopefully guide you into an interesting talk before we take a break. So this is near and dear to my heart. Let's see here. There we go. Okay. So just to let you guys know, I do not have any conflicts of interest or financial disclosures to report. Today, the main objectives that I will talk about are vision screening during childhood, visual acuity screening guidelines that we typically follow, nonverbal signs of visual acuity and difficulties in children, and some technologies that we use along with the ophthalmologist, but also mostly with pediatricians to enhance screening efficiency and to pick up childhood eye disease. So while we as ophthalmologists have recommendations for timing of eye exams, we really rely mostly on the pediatricians and school nurses, other medical professionals to be the front line of picking up childhood eye disease. They're our first line of defense. So they're the ones that trigger a lot of referrals to our services. And the primary reason, far and away the most common, is amblyopia, which can be commonly referred to as lazy eye. So what is a strict definition of amblyopia? So this is a decrease in visual development that happens when the brain doesn't receive normal stimulation for one or both eyes. So the way I look at it is, and the way I describe it to my parents, is that it's any sort of visual obstruction, whether it be one eye or both eyes, leading to the pathway from the eye to the brain. And this abnormal development can lead to permanent visual loss if not treated or picked up early enough. So the difficult aspect of amblyopia, that it is a childhood disease. So the problem with that is children, when they're developing, are nonverbal. So they can't give you an accurate subjective measurement of vision. So it's up to us to develop ways of which we can try to screen these children and pick up some of these risk factors. In fact, amblyopia is one of the most common causes of visual impairment, even in adulthood. So adults 20 to 70 years of age, one of the most common cause of visual loss is untreated childhood amblyopia. Now, there's different etiologies of amblyopia. There's many, many different reasons why. Some of the most common reasons are untreated refractive errors, strabismus or eye misalignment, and then any sort of obstruction to the visual axis. For example, cataracts, ptosis, corneal scarring, anything that you could think of that would cause an obstruction. The National Eye Institute reports that amblyopia affects about 2 to 3% of children in the United States, which does come out to an estimated almost 5 million children with this preventable form of visual loss. So screening early is best. So that's why we rely on many, many different healthcare situations to pick up some of these risk factors to childhood vision loss. And the unfortunate thing about amblyopia is it can become permanent, this type of vision loss if left untreated by 7 to 8 years of age. However, it is treatable, so it's important to pick this up. Unfortunately, there are barriers to screening. Obviously, a lot of this has to do with exam. We have poor cooperation of young children, especially 15 months old. I find the most difficult age to examine. This takes a lot of time to perform. The staff many times are not adequately trained, which is why we find these talks important, so we can train you how to help us in terms of examining these children. A lot of times unfortunately, there's a shortage of pediatric ophthalmologists, and a lot of this can go to some financial discussions, which are not privy to this talk, but it's poorly reimbursed. So many physicians and or optometric professionals can't perform these exams because they have to keep their doors open. Also, which I don't mention here, but this would be a whole separate talk, is I also wholeheartedly agree that there are also significant socioeconomic factors that do come into increasing barriers to screening, just from my time, obviously working in the Bronx and downtown in New York City. So there are age-dependent thresholds of which we use in terms of guidance and which will trigger an eye exam to an ophthalmologist rather than just a medical professional. And we'll go through some of these screening guidelines. The American Academy of Pediatrics has a mission statement which does endorse instrument-based screening as a frontline screening for children 12 months and over. I've noticed recently that most pediatricians will actually start at 9 months of age to pick up any sort of risk factors, especially if they're concerned, which is great. The earlier the better, quite frankly, because we've even picked up, you can pick up issues as early as 3 to 6 months of age. However, it is important to note that direct measurement of visual acuity with a pediatric ophthalmologist still remains the gold standard. And if you pick up any sort of risk factors on photo screening, that should prompt a full evaluation by us. And important to the topic today and technicians along with ourselves is an exam. So making sure that we are, once they prompt an eval from us, that we have an accurate assessment and an accurate exam. So when you're checking a vision in a child, you have to make sure that you have full occlusion of the non-tested eye. So children should be tested monocularly, one eye at a time, not binocularly, and occlusion with sort of what I call an eye band-aid is the best because they are inherently great cheaters. So you can't use plastic occluders. You actually have to fully occlude their eye. Just to kind of highlight some age groups. So newborn to 3 years. This is a group of children where, obviously most of them are nonverbal and or just learning vocabulary words, their alphabet. So they may not know numbers, they may not know letters, they may not even be comfortable telling you their shapes yet. So we rely a lot on our exam in this group of children. So, and really what is most important to us is symmetry. So is there a symmetry between each eye? Are they behaving similarly together? So when we're checking vision, we make sure that they're tracking the same. They're not objecting to occlusion over one eye versus the other. Obviously, you can't pick up subtle defects in this age group, but you can pick up any sort of gross motility defects, strabismus, and or any large obstructions to the visual axis. And I'll go through some of these more subtle findings that especially are important for ophthalmic technicians as well as ophthalmologists when you're checking vision in a child, that you can pick up some of these subtle differences in kids this age. So when you move from 3 to 4 years of age, these children are typically now starting to be in school. So they're starting to learn their letters, they're becoming a little bit more educated. So we're happy if they reach, the majority of them reach the 20/50 line. They still don't have to read 20/20, and that's important to sort of remember is, children, despite the fact that they may have the potential to see 20/20, we use different testing tools, for example, stereo acuity or a near vision. Other aspects of our exam will help us reassure us that they have the potential to see 20/20, because these are, again, just to remind you that they're subjective testing. And then once we finally reach school-age children, 4 to 5 years and above, we are going to start to become a little bit more stringent in terms of what we expect for them to read. So 4 to 5-year-olds, if they read the majority of the 20/40 line, we're happy. Honestly, in all honesty, most of the children that I see at this age, they're reading 20/20, if not better. So if a child really does read 20/40, I suspect that there might be some sort of mild amblyopia. And as I said here, 5 years and above, we do expect them at this point to read 20/20. So some of the nonverbal exam signs, which are easy to pick up once you have enough experience with these children. As you can see here, strabismus, which can be pretty obvious or sometimes can be pretty subtle. Here, a child, just to review, is esotropic. You can see, you can use just your pen light or a Fenof light source to look at the pupillary light reflexes. And here you can see that this is temporarily displaced, showing that this patient does have esotropia. The eyes are turning in. Here you can see here that the child now has nasally displaced pupillary light reflex, and he is exotropic. Both of those are pretty obvious examples. This was a resident, the chief resident of mine down in New York. He's now in private practice in California, and he was kind enough to sit for pictures for me. And here he's not wearing his glasses. Obviously, you can see that he's struggling a little bit. He's squinting his eyes. Not as common in children that they squint like this. In older children, teenagers, and adolescents, you'll see this. But it's almost more common that you actually see this. So you'll see a child without glasses, they'll turn their face to their side. That is a form of squint in children, and typically means a high refractive error, usually in the form of astigmatism, but it can be any refractive error. Also common in kids who are have significant hyperopia or farsightedness, you'll see that they usually put their chin up or their chin down. So I'll ask the parents commonly when they're looking at TV or they're reading a book, what are they doing? Show me a picture, or I'll give a child a book if he's of reading age in the chair to see how he behaves, and that will give me some sign of if he's got an imbalance or a high refractive error and needs glasses. Additionally, in younger children and other nonverbal children, Brechner reflex testing can be really important and a powerful tool. You can actually look at refractive error imbalances between them, particularly anisotropia, meaning one eye has a different refractive error than the other. And you can look at these crescents. So typically if you see an inferior crescent, it would be indicative of a patient who is highly myopic. Secondarily, you can see a superior crescent in a child who has high hyperopia. Emetropia, you'll be able to see sort of this nicely lit, just red reflex, and I can show you some examples here. Here's a picture of a child who has high hyperopia. You can see this kind of lightening of the reflex or a superior crescent, and this is a patient who has strabismus, and you can certainly see that there is a difference in the quality of the light reflex in a Brechner testing. Much easier when the patient's dilated to check this. We do have targets and guidelines that we follow in terms of refractive errors. So when do we push a child into glasses because of a risk of amblyopia? So we follow this, and typically it is age dependent, but most of it typically is based on the amount of hyperopia or the amount of astigmatism between each eye where we will push them into glasses. So if a child has about 2.5 diopters of astigmatism, we will be concerned that it can be amblyogenic and place them into glasses. Additionally, anisotropia is about the same as astigmatic change. Hyperopia tends to be a little bit more forgiving in terms of when we push them into glasses. However, this is in the setting of a patient without strabismus. So if they have strabismus, that changes our guidance significantly. And then myopia. certainly in children becomes more stringent as they become more older in terms of when we're going to push them into glasses. So just in sort of to finish up the talk here, just to talk a little bit briefly about photo screening technology. It's an interesting field because we rely specifically on old school testing, streak retinoscopy, a cycloplegic exam, but we have adopted photo screening technology even within our clinics, as well as within, pediatric practices to pick up some of these refractive errors. I typically use photo screening technology just to help me as a starting point to bounce off refractive errors, and then also to double check if I have a discrepancy in my own refraction compared to what the computer picks up, because sometimes they actually can be more accurate. The state of the child's cooperation can change moment to moment. So sometimes we have started adopting this more and more within our own practices. So instrument screening is really useful for children 1 to 3 years of age, especially those, as I had mentioned before, that they can't subjectively tell us a vision. And in children about school age or a little bit older, we tend to want to try and do a subjective visual testing. But like I said, it can be a powerful tool when we're picking up refractive errors and want to confirm a correct glasses prescription. And then thirdly, in older children and adults who are developmentally delayed or unable to perform any sort of subjective testing, it can be really, really helpful in detecting some significant refractive error. So the difference between the screening, so there's basically, 2 different types. Obviously, we can get a visual acuity, a subjective measurement, and able to, put that into an objective measurement of what a correct vision would be. However, screening instruments don't give us a visual acuity. So that's important to remember, is that it just can give us a refractive error or sort of an anatomical asymmetry. So they're only going to test for refractive error and or strabismus or any sort of absence of red reflex or asymmetry. And again, you have different types of photo screeners. So some of them only will detect the prescription of an eye or an autorefraction, and then others will only detect misalignment or strabismus. When a pediatrician refers a patient, it is important to know what type of photo screener they use, the quality of the photo screener, and what they're referring for. So some of the common visual screening instruments, as many of you have used at this point, obviously, is the Retinomax, which is a handheld autorefractor. Those are definitely user dependent. I find them even challenging to use. I use them a lot in the OR, but a lot of times I rely on my own streak retinoscopy as the gold standard. Plus optics, these are just different brand names. And then commonly we'll use the spot screener, which I think is relatively accurate, but can overestimate sometimes refractive error, especially astigmatism. This is one of the newer screening additions that we have, which is now an iPhone-based photo screener. I find this powerful in the sense that it typically analyzes the red reflex. They're developing the autorefraction portion of this. But obviously with the advent of iPhones and the use of screen time, children really tend to gravitate towards an iPhone. So you hold that up and you can actually get a pretty accurate measurement because they're looking at the phone and trying to reach for it. So I've used those before. There's some debate on how accurate they are, but I think they tend to be pretty good screening tools. The instrument screening, as I had mentioned before, is endorsed by the American Academy of Pediatrics, as well as APOS, our own Association for Pediatric Ophthalmology and Strabismus. And in some studies, they even mentioned Sean Donahue, which is he's just a wonderful researcher, had looked at here specifically, is instrument screening actually better than visual, subjective visual testing? And it may actually, some of these studies actually show that it may be more accurate. However, these are done in a pediatric office, not a pediatric ophthalmology office. So obviously, again, the gold standard is to get a cycloplegic refraction and a streak retinoscopy by a pediatric ophthalmologist. And that concludes my talk. And I just wanted to say thank you very much again for inviting me here. And I really enjoyed, I'm enjoying meeting all of you guys.
Really appreciate your time. And it's nice to welcome you to Connecticut as part of Yale faculty.
Thanks.
I have a question for you. It's a little bit outside the scope of what you talked about here for evaluation, but I always think about the treatment side of amblyopia, and I grew up professionally in the time of patching, and then we were using eye drops for it. What's new on the horizon? Once we discover amblyopia, what do we do about it?
Yeah, well, I think some of the screening, it really hasn't changed much. I will tell you that, patching has been and still is the gold standard. Obviously the first thing you do is you correct the problem at hand. So if there's a refractive error, you have to correct that. And many say that the patching will augment the treatment to what you're reversing in a sense. Now, over the last 10 to 15 years, with the invention of PDIG studies, where we've started doing a lot of the evidence-based trials on how much patching. So that's what's really changing is our algorithms in terms of what we guide patients in terms of how long they have to do therapy. It used to be that you would patch them all day, 12 hours a day. And they've done trials now where they compare 2 hours, 6 hours, 12 hours, depending on the severity of the amblyopia. And it's really changed the compliance, because we found that there wasn't a huge difference between 2 hours and 12 hours. There are some, modifications, and many of us still will sort of guide therapy depending on how severe it is and go past 2 hours. So that's one aspect that has really changed and improved the compliance greatly, because now kids don't have to patch in school, and they can do it at home, and they don't have, because many of them get embarrassed when they have to go to school and wear a patch, and so that's one really exciting aspect that we have learned over the past decade. And then secondarily is how long. So, do you continue patching? Is it really the age of 8 to 10 where we just sort of give up on patching? And there are some studies showing that you can actually push them a little bit farther and get some benefit even past the age of 8 to 10. So some pediatric ophthalmologists will even push to age 12, depending on, many factors of compliance and their desire to do it. I'll even patch adults who haven't patched previously and who are motivated to try. You'll subjectively, they will sometimes show a little bit of improvement, but subjectively they'll tell me that they see better. Whether or not that's placebo effect, it's hard to know, but if I feel like it, it's making a difference in sort of their care, I think that's a powerful thing. Additionally too is we, while we sort of poo-poo screen time, a lot of our technology too, it's still a bit of a, this would be sort of a controversial talk, but is how we patch. And then, is there, are there computer-based systems to where we can essentially confuse the brain and do it without patching? So using a computer-based algorithms to essentially occlude an eye visually using a computer without patching. So there's a lot of different technology out there that they're trying. None of it's been quite validated yet, but it is sort of exciting to learn about, I think.
Yeah, and it was interesting to see you bring up an app for the diagnostic side of it. And I just wonder, when are they going to make an app for the treatment side of it?
Yeah.
So
Oh, yeah. I'm sure it's coming.
Yeah. Our is at what point or what's your threshold for pharmacologic blurring?
Yeah.
Like,
Well,
who
so
gets
I
that?
tend to be a little bit of a traditionalist with pharmacologic patching. So, it doesn't necessarily work in myopes either. So it's in patients who typically have hyperopic anisometropic amblyopia. So we don't really see the benefits in myopes as much. So I try everything I can do with occlusion patching, because there's a lot of factors that come into play too. It is a longer based therapy. However, compliance to it, are they getting the eye drop in all the time? Are they getting it in every day type of thing? A lot of times I'll have patients come back and they're supposed to be dilated and you can tell that they haven't been using it because their eyes just, so I'll augment it. I'll push them if I've failed traditional therapy with eye drops.
Okay, well, thank you again. It was great coverage of the topic. We appreciate your time.
Thank you
Have a
very
great
much.
day. All right, so let's, the next on our agenda is to go to a break. The break's from 3:30 to 3:45. However, of course, we're not going to let you get away for free just that easily. We are going to offer some door prizes, so keep an ear on your computer. Again, I would like to thank Regeneron for their generous support for this program and being an integral partner of our education mission of both the Connecticut Society of Eye Physicians and NISOS. Our next meeting that we're going to have, we're hoping it will be live. It'll be in June of 2022. Hopefully we won't have to default back to the virtual because we would just love to see everybody and have that otherwise together time and share a meal with each other. So we are very interested in being responsive to your needs. So in today's meeting, if you are thinking of topics that you would like to hear or topics that you've heard and you'd like to hear more of, or speakers that you'd like to have come back and spend a little more time with us, please let us know by filling that in the chat box, and we'll take that into account. We set up the agendas for these meetings pretty early on, but we can arrange that either for the next meeting or the meeting that's coming up. So let us know what you think, what works, what doesn't work. If you love the virtual, why you love the virtual and why we should stick with it. So there's lots of different things. We're looking for your input on this topic, so feel free to share with us. The next topic I want to cover is your CME credits. If you want to get CME credits, first you have to be on the attendance list to get the credits. So you are, because you're here, but that's a very important part of it. If you want JCAPO credits, you'll need to pay the $45 charge for those credits. So if you registered, and most of you have already, those of you who need the credits, but you still have an opportunity to pay and receive those credits through iJCAPO. There is a post-test online that you'll need to fill out. And so this is the way you get there. So sign on to the website, ConnecticutSocietyofEyePhysicians.com, and go to the left bar on there that says home at the top, go down to meetings and click on upcoming meetings. And then that'll take you to a different screen where we want you to scroll down and click on the highlighted line there that says click here for online CME evaluation for CME certificate. And so on there, you fill in your name, your email address, fill out the CME evaluation, and then we'll make sure that you get your certificate. And today's course, if you're here for the whole thing, is worth 5 1/4 JCAPO Group A continuing education credits. So make sure you go to the website, and there are other educational opportunities at the website. So check it out while you're there, and make sure you sign up for your CME credits. So again, a big shout out to Regeneron. Thank you again so much. They've been helping us and being part of this education effort of ours for many years. We hope to maintain our relationship with Regeneron as the years go by. So thank you, Regeneron. So now I'm going to turn this over to Deb Osborne, and we'll go to some door prizes. Again, take a break, stretch your legs, have something to drink and some food. And we're going to continue on after the break at 3:45 with a practical approach to patients with dry eyes. So Deb, door prizes.
Ed, you are wonderful. Okay, so first of all, I am not thrilled with these Zoom presentations. They're doing a great job, but I am freezing my tush off sitting here watching this thing. Normally, I'm running around like crazy, Ed, right? So I probably gained, 2 pounds sitting here because all I'm doing is eating pistachios. And but what a great lineup you have there, and you're doing such a great job, Ed. So I'm going to stop the recording.
We hear visual complaints from our patients, and they can perplex us as we search for reasons for people's discomfort and vision complaints. So he'll be covering the basic physiology of dry eye disease and some of the appropriate tests that we can use, and discuss some of the treatment options for dry eye disease in his talk titled A Practical Approach to the Patient with Dry Eye. Welcome, Dr. Winnicor.
Thank you so much for inviting me. It's really a pleasure to be here. Hopefully you guys can see my slides.
Yes.
All right, fantastic. So today we'll talk about a practical approach to patients with dry eye disease. Okay, so what we want to do today is to understand the basic physiology of dry eye disease and its associated conditions. We want to figure out what kind of tests we need to do in these patients who have, ocular surface disease and dry eye, and then discuss some of the treatment options here. So what is dry eye, right? It sounds pretty simple. If it's dry, wet it. If it's wet, dry it, and we're done. That's kind of stolen from dermatology, but is it really that simple? And of course, it's not, unfortunately. So when we think of dry eye, we think that, okay, there's some dryness either due to lid disease, or they're dry because they're not making enough tears, and there's inflammation, and it's a bad cycle, and it's a pretty simplistic way to think about it. If you think about it a little more carefully, there's probably a little bit more stuff going on. There's problems with the composition of the tears, there's problems with inflammatory mediators, there's problems with nerves, there's problems with blinking, and that's a little more complicated. And then you can really dig down deep, and then you really get lost because you're like, wow, there's actually a lot of stuff going on for a problem that we view as a pretty simple problem. So let's start maybe simplifying it a little bit, right? What is dry eye? What is dry eye? So dry eye syndrome, it's become really a very overly broad diagnosis that we use, and we blame most symptoms of itching, burning, tearing, foreign body sensations, some mild vision. We blame this all on kind of dry eye. So a patient comes into the office, and we kind of put them right in that box. But the truth is there's a very large differential diagnosis for the similar symptoms, and that can be due to what's called neurotrophic keratitis or allergic conjunctivitis. There can be contact lens issues, chemical issues in the eye, infectious issues. And so really it becomes, and there's more and more and more. And so these symptoms are very, very non-specific. So again, let's use the KISS principle. Those of you who've heard this before, KISS, keep it simple, stupid, right? So let's keep it simple. Let's take a patient example. So let's say we have a 55-year-old woman, and I chose a 55-year-old woman because usually this is, the prime demographic that you're going to see this, because a lot of dry eyes are hormonally mediated, and so it's very common to see older women with complaints of dry eye. And so in this example, she's complaining of itching, burning, and tearing with no visual complaints at all. So you think it's dry eye. So think for a second, what do you want to ask this patient? What do you want to get down to try and help narrow it down to see if it's dry eye? So like everything else in medicine, history is going to be a huge help for us. And it's going to make the diagnosis most of the time just talking to the patient and finding out what's going on. So you want to find out how long this is going on, how long have they had the symptoms, are the symptoms intermittent or constant? So are they all day long, or it's really just when they're using the computer, or when they're reading a book, or when the wind hits them when they're outside? Are there any mitigating factors? Does anything make them feel better or worse. Past ocular history, past medical history, what kind of meds they're on, what kind of other things that they have going on, and what other signs they have. And I've put a picture up of hands here. You know, one of the things that I like to do, or at least I did like to do before COVID, is shake a patient's hand. And sometimes you just look at their hands and you can see that there's something going on there. So these hands are kind of typical of rheumatoid arthritis, and people of rheumatoid arthritis typically have dry eye that are associated with it, and it can be quite severe. And so just looking at their hands, just looking at their body can sometimes give you an idea in terms of what's going on and what's the underlying issue. Going back to these kind of little flow charts here, you know, I try and break down dry eye into different causes of dry eye. So you can be dry because you're not making enough tears, or you can be dry because you are making enough tears, but the quality of the tear is not very good and it's not doing what it needs to be doing. In addition, you can have mechanical dry eye. So you can have dry eye because the lids aren't working, or there's something going on that's not allowing the eyes to work well. You know, the blink is really important to spread the tears around. And if you have neurological issues or actual physical issues and lids aren't working right, then that makes it worse. And also, I like to think about inflammatory conditions. So that's sort of the 4 boxes that I use when I'm trying to treat a patient with dry eye. And the boxes are important because they're going to also guide the therapy in terms of what are we really treating here. So let's go back just for a few minutes and talk maybe about some of the basic science stuff behind dry eye and what the tears do. So the tear film is the layer of tears that you're making that coat the surface of the eye. It's important to smooth the optical surface. So there's some micro irregularities on the surface that tear film will fill in those gaps, and you'll have sharper vision with good tears. A major complaint people with dry eye have sometimes is this intermittent blurring of the vision. And so having a nice smooth optical surface is important. It also removes debris from the surface of the eye. It protects the surface of the eye, and it supplies oxygen and nutrients to the corneal epithelium. In general, the cornea is an avascular tissue, and so all of the oxygen that it gets is not from our red blood cells, but actually from the environment, and the tears help supply some of this to the eye. Very simple schematic of the surface of the eye and the lids. We see that there are lacrimal glands. So there's a main lacrimal gland, and then there are accessory lacrimal glands in the conjunctiva. There, you have your conjunctiva, which holds what are called goblet cells, which create mucin. And then you have meibomian glands and lids, which create oil that helps with the eye, and we'll get into that stuff in just a minute. The tears themselves are complex. It is not just water. So, you know, you sometimes I'll hear patients saying, yeah, splash water in my eye, felt, you know, to try and make feel better. It's not working. Tears aren't water. Water is a main component of the tear film, but it's actually fairly complex. So we think of tears as having 3 layers. There's the lipid layer, which is provided by the meibomian glands. There's a water layer, which is provided by the lacrimal gland, and then there's the mucin layer, which is provided by the goblet cells in the conjunctiva. So let's talk a little bit about the lipid layer. So the lipid layer, again, is formed by the meibomian glands. These are in your eyelids. There's about 30 of them in each eyelid, and they squirt out a little bit of oil, and they help create an emulsion of the tear film. And basically, they help the tears from evaporating quickly because now you have a mix of oil and waters. They maintain this a little hydrophobic barrier, and it increases surface tension, so it prevents tear overflow. It's somewhat optical, and it prevents damage to the lid margin by the tears. And here are the meibomian glands. They're right behind our eyelashes. You can see these little dots. And these are pretty decent meibomian glands when you look at them. This is what it would look like if you look at a past slide. So if you looked at it, you can see these glands here that are in the lids. And this is what it would look like when the meibomian glands are not so good. So in the slide on your left, you can see this kind of white, thickish stuff. That's clearly not a good flowing oil. It's really thick. And on the picture on the right, you can see what's called meibomian gland capping. So basically these glands have formed a cap of oils that are not going anywhere. They're just getting stuck there. There's also an etiology for why people get styes. The oil gets really backed up and leaks around, and then they get tender and red, and it's super uncomfortable. Okay, so as far as the aqueous layer, The aqueous layer is formed by the lacrimal gland, and it contains more than just waters. There are electrolytes, proteins, solutes. So all these things are basically there to perform biological functions that we need. This layer helps to oxygenate the corneal epithelium. It maintains a constant electrolyte composition. It provides some defense for bacteria. It smooths the surface, it washes away debris, and it modulates corneal and epithelial growth. Okay. The mucin layer is formed by these goblet cells in the conjunctiva, and it contains mucins, proteins, electrolytes, and water in this layer. And it basically allows an even distribution of the tear film, lowers the surface tension somewhat. It traps dead cells, bacteria, and debris, and it lubricates the eyelids as it passes over the globe. And this is just a schematic of what the conjunctival epithelium looks like. So when you actually look at the pathology of a conjunctiva, you'll see there are these goblet cells, and on the left side of your screen, you'll see that's actually what it looks like. There are like these little glands within the conjunctiva. Okay, so tears themselves, the reflex secretion of tears is neurally mediated. So what does that mean? So basically, there are different ways that we can secrete our tears. There are physical irritations, which is mediated by cranial nerve 5. It can be psychogenic. So when you're sad or happy, you can tear, and light via cranial nerve 2 can cause your tears to come out as well. Okay. So as far as dysfunction, so what happens when the tears are dysfunctions? Well, there are a lot of different reasons why they may be dysfunctional. You can have a change in the amount of tears that you have going on. So that's not just, that's basically the quantity of tears. There's a change in the constitution of tears. So that's the quality of the tears. It's not great. There's an uneven distribution of the tears. That can be due to an irregular surface, or you can have ineffective distribution of the tears because your eyelid is not working well, or the globe's not right, or something's going on. And again, there's inflammation. So going back to what we were talking about before about those 4 boxes, those 4 boxes are basically here. It's quality, quantity, movement, and inflammation. Okay, and here's just a photo of some dry eye, and we see some corneal staining over there, those bright green dots, as well as some actual dry spots where the tears are evaporating. So if we were to ask you a question, I think this is one of the questions that we have: which of the following layers is not a component of the precorneal tear film? Well, we know that tear film is mucin, lipid, and aqueous, so the answer would be C, keratin layers, not part of it. All right, so once we're done with our history, we want to do an exam. We want to see what's going on. So when we're evaluating for dry eye, we're trying to say, okay, do the lids close? Are they moving well? Is there evidence of eyelid surgery? People who've had blepharoplasties, cosmetic blepharoplasties often changes the anatomy of the eyelid. And even though they're happy with the cosmesis, the function of the lid is affected. Is there excess conjunctiva? That's something called conjunctivochalasis, meaning, and I'll show you some pictures of that later, but does this look like a normal eye? From a technical point of view, from a technician point of view, a lot of times what we do is we're checking the pressure. Most methods that we use to check the pressure require topical anesthetic. Now, topical anesthetic can cause a worsening of the exam in patients with dry eye. They're dry already, and now they're not blinking, so their eyes are going to get worse, plus the drops themselves are somewhat irritating. So depending on your office, the person you're working with may prefer not to use topical anesthetics before they look at the patient. They may want to see what's going on before the pressure is taken. But when a topical anesthetic is placed, does that relieve the symptoms? So if someone comes in with itching, burning from dry eye, and you give them a drop of anesthetic, usually it's like, wow, that feels much better. Versus if it doesn't feel better, then you may be thinking about the wrong thing, and that may not be the right diagnosis. All right, so we spoke a little bit about some lid dysfunction, and here we see a couple of people who are, some are after eye surgery, some are because of neurological issues, but we can see that when the eyes are closed, for example, the picture on your left, the left eye in this patient is just not closing. So that's going to definitely cause a bit of a dry eye. We see the center picture, patient's closed, the medial aspect is way open. So that's some sort of eyelid malposition. And then we see on the left side, on our right side of the screen, somebody trying to close their eyes where one eye is just not closing. And that could be due to a number of things, could be nerve dysfunctions from various reasons. We spoke a little bit about conjunctivochalasis, and that's that excess skin that you would see And the problem with that, in picture A, you can see that there's an excess of conjunctiva on the eye, and in B, we're pulling the lid down, pulling the conjunctiva down, and now we can actually see the bottom of the eye. So why is this really a problem? Well, because every time they blink, they're rubbing their eyes. Their conjunctiva is rubbing against the cornea, it's rubbing against itself, and it causes similar conditions. So sometimes you see this, and this is a whole separate entity of what causes these same, quote, dry eye symptoms, but may not necessarily be from a tear dysfunction or a quality issue, just maybe physical, that the eye, there's something going on causing these issues. So there's a bunch of special tests that we can do to evaluate the surface of the eye. Some of these are going to be done routinely, and some of these are going to be done extremely rarely. So I'm going to go through this list with you right now. Corneal fluorescein staining, very common test, right? We do it on almost every patient we see. Basically, we put the fluorescein into the eye and we see where it gets taken up. Usually gets taken up in the areas where the cell junctions are broken or dysfunctional, and dry eye is going to break down some barrier between the cells. And so we're going to see these little speckled patterns over here. If you look at the green picture, you can see that staining pattern inferiorly, but nowhere else in the eye. So patient's going to complain of dry eye, but why is it just in that one area? Well, probably because they're sleeping with that eye open just a little bit, and one area gets really, really dry overnight. And so then no matter what they do during the day, it's not helpful. And the other pictures, the center picture over here just shows diffuse staining. So just dry across the board, whereas the last picture is kind of not dry on top and very dry on the bottom. So maybe there's a problem with their blink. Maybe when they blink, they're not really blinking fully. So sometimes the patterns of what you see can help guide your diagnosis. The tear breakup time is also something that we'll use. This is more of a test of a quality of the tear. So for instance, in the picture labeled A, we just put the stain in, and then the picture with B, we can see that there are dry patches appearing. Now, if they keep their eyes open long enough, these are always going to appear, but ideally you want the tears to last about 10 seconds between a blink. When you're seeing them break up quicker, so in the picture on the bottom, we see like 5 seconds, all these dry spots, you know that there's a quality issue, meaning the tears are really supposed to remain a nice solid film over the eye, and it's clearly not for long enough. So that picture right here, or this exam finding right here, would tell you, okay, this is a quality issue. And this is kind of a picture of the same stuff, where you just give it time and then the tears just start breaking up. Okay, dye disappearance test. Sometimes people will complain of tearing, and you kind of assume it's dry eye, but you put the dye in, you take a look, and you see one eye is got a lot of tears and the other eye doesn't, meaning a lot of staining in the tears. And if you wait 5 minutes, it's still there, that dye is there. That's more indicative of an obstruction of the nasolacrimal system, meaning they're not draining their tears away well. And that's actually not dry eye. That's going to be something else. So this kind of stuff will help you differentiate between symptoms, between conditions that have similar symptoms. Anesthesiometry. One of the issues people get dry is they have neurological issues associated with the cornea. The cornea sensation is not normal, so they're not blinking a lot, and the eye doesn't know to put out more tears because it doesn't sense the dryness. So you can do an anesthesiometry. This is a Cachet-Bonnet anesthesiometer. Basically what it is, it's a little fishing wire that goes into this instrument, and you can advance the wire from very, very little coming out of the probe to a lot. So usually what you'll do is you'll take the filament all the way out of the instrument and you'll touch it against the cornea. And you can imagine that a long string, if you touch it against the cornea, it will kind of just buckle a little bit. So it's not a lot of force that you're putting on. And if they sense it when it's all the way out, they have great sensation. But if they're neurotrophic, meaning their nerves aren't right, then they won't feel it. So you'll make the string shorter and shorter until they actually do feel it. You can imagine at 1 millimeter, that's a really tiny string. When you're poking it, it's going to not really bend very much. It's a lot of force. So it's a way to kind of document what their neurotrophic status is, and say, yes, they're definitely neurotrophic, and here's how much they were neurotrophic. Not everybody has these in the office. A lot of times what people do is they just take a cotton tip and they kind of twirl it in their fingers. They make a little filament and they say, do you feel this? Do you feel that? And they kind of poke around gently a little bit to see what their sensation is. Meibomian gland expression. So sometimes you want to take a look at the meibomian glands and see, do the oils come out easily when we push on it, or are they thick? So here we have a little video which I found of just watching somebody do this. And this is an instrument, but you can use your hands. You can use your thumbnail pushing against the lid, and they're squeezing the meibomian glands. That's not normal. That's like thick toothpaste-like stuff. It looked okay when we looked at it before we squeezed it, but now that we're squeezing it, we can see that this is not normal oil. So there's going to be a quality problem here. Okay, Schirmer's testing. I love Schirmer's testing personally. I see a lot of patients who come to me for dry eye, and they've seen somebody and they said, yeah, they said I should put tears in. It didn't help. What do I do next? And for me, it's hard to tell, is this a quality issue, a quantity issue? So the Schirmer's test will test quantity. How many tears are you making? And there are different ways you can do the Schirmer's test. And I hate the nomenclature. I can't stand it. Schirmer's 1, Schirmer's 2, very confusing. Very, very briefly, there's something called a basic secretion test. That's basically, I'm putting a drop of anesthetic in, I'm numbing the eye up. I'm going to take away any excess liquid in the eye, and I'm going to put these little paper strips under the eyelid, and I'm going to wait 5 minutes, and I'm going to see how wet the strips get. Usually you want to see the strips at least 10 millimeters, 15 is better, after about 5 minutes that are getting wet. If they're super low, it means they're really not making a lot of tears as a baseline. If it's super high, they're making something. So it gives you an idea. Again, difference between 13 and 14 and 15, probably not that big a deal, but you'll have patients that have a Schirmer's test of 2 and some that'll have, of 30. And you'll know the ones that have 30 are okay and the ones that 2 are not. And everyone in the middle, you sort of have to decide based on history. The Schirmer's 1 test is without anesthetic. So you're basically putting that little piece of paper in, but you're not numbing the eye. You want them to feel it. And you want to see not only what's their baseline, but also how much tears can they produce as a result of an irritation. And so somebody that you do a Schirmer's 1 test, meaning no anesthetic, and they're still super dry, you got a real problem you got to deal with. Usually you want to see them go about 5.5 millimeters or so after about 5 minutes. Below that is considered a positive test. And a Schirmer's 2 is without anesthetic, but not only are you irritating the eye, you're stimulating the nose. You're jamming a cotton tip in their nose and you're irritating them. And that will give you the maximal secretion of the lacrimal gland. I don't think I've ever done that, but that's one way you can do it if you're trying to figure this out. So if I were to ask you a question, which of the following tests measures basal tear secretion? Would it be a Schirmer's 1 test, a Schirmer's test with anesthesia, a tear breakup time, or a fluorescein staining? You would say, well, it's the Schirmer's test with anesthesia because that's the baseline tears. Again, I don't love the Schirmer's 1, Schirmer's 2 nomenclature because it's actually very confusing. So usually what I do in my notes, I will write Schirmer's test with anesthesia, Schirmer's test without anesthesia, or if I were doing the other one, I would say Schirmer's test without anesthesia and nasal irritation. That way, when someone else reads your note, they know exactly what you did. Okay, exophthalmometry. So this is something we use for thyroid eye disease or for things that are causing what's called proptosis, which means the eye is coming out. People with Graves' disease, their eyes often become more prominent. You can see the sclera on top of the eye. Thyroid disease in general is associated with dry eye disease, but certainly when the eyes are proptotic, things are worse. So you may want to see, if you're not sure if someone's proptotic, it's pretty obvious from these pictures that these people are proptotic, but you're not sure. You think maybe it's a little large. So you can use this device, and basically what it does, it rests on the bone, the lateral canthus, and then you can use these mirrors and this prism, and you can kind of measure how far out the eye is sticking from the bone. And that's something that sometimes we like to document and see what's going on. There's something called meibography, which is basically infrared pictures of the meibomian glands. Typically, the only practices that are going to have this in their office are those that offer what's called lipoflow, which I'll come back to. But basically, this is a way we can image the meibomian glands and see what's going on. And you can see from normal to abnormal, you can see loss of the meibomian glands, you can see engorgement, you can see different things. So you can see if someone's okay or not okay. And then there's tear osmolarity, which basically tests the salt content, more or less, of the tears, and this may help differentiate dry eye from other diseases. So if you have someone with the symptoms, itching, burning, tearing, forehead, body sensation, and their osmolarity is totally normal and their Schirmer's is normal, maybe you're going to think, well, maybe it's not actual dry eye, maybe it's allergic conjunctivitis, and they may help you in that way. So which of the following tests is not used to diagnose ocular surface disease? So meibography, tangent screening, corneal staining, or tear breakup time. Well, we covered 3 of these. We covered meibography, corneal staining, and tear breakup time. So tangent screening is something else. That's a visual field test that neuro-ophthalmologists use. Okay, and which of the following tests is the best approach for diagnosing a patient with a dysfunctional tear syndrome? OCT, corneal topography, tear breakup time, or eye pressure? Well, if it's dysfunctional tears and the tears aren't working very well, the tear breakup time will tell you that, hey, these tears are not working very well. So the other tests are all for different things. Okay, time to talk about the treatments. Treatments are, there are a lot of treatments, very confusing. You don't know which way to go. And when you see this many treatments, that's because none of them work, right? If one of them worked every time, you would just say, do this, but they don't. And that's because, again, the pathophysiology of dry eye is so varied from patient to patient that, you know, someone who has low aqueous production, not making enough tears, they're not necessarily going to be helped by fixing the meibomian glands, and vice versa. So you have to kind of figure out why they're having dry eye and then go for that. So I'll try and go through this really, really quickly. Aqueous deficiency, use some tears, different kinds of tears out there. You have big bottles of tears, they typically have preservatives, and then you have the little vials which don't have preservatives. The ones that don't have preservatives, you can use them all day long. The ones, if you have them with preservatives, you may want to limit them because they will irritate after more than 4 drops or so a day. Another treatment would be medicines that help produce more tears. So there's Restasis, Xiidra, Cequa, and these are basically anti-inflammatory drops that help reduce inflammation in the lacrimal gland. And then when the lacrimal gland is not inflamed, it works better, and so you're getting more tears. We can also do ointments, and this is probably the best way to put ointment in. Sometimes a tear is not good enough. You need something that lasts longer. You can use gels or ointments. Electrostimulation. Boy, this looks pleasant, right? This is the true tear, but some patients really love it. They say this is great. And basically they put the device in their nostrils and it creates a little electric current and makes them tear more. You can have secretagogues. So these are medicines that actually force the glands to secrete more. Pilocarpine is the typical one. That was called the Voxac, and that's an oral medication. And now there's a new nasal spray, Trevia, which just came out. I don't have a lot of experience with it yet, which also helps produce tears. Punctal plugs are amazing. I think they work really well. There are silicone plugs and there are collagen plugs. Basically, what you're doing is you are blocking the drainage of tears. So they're still making tears, but you're going to prevent those tears from going away. So you're putting them in the punctum and you're not allowing the tears to escape the eye through natural means. I'm a big fan of the collagen ones. They last 3 months, 6 months, more so than the silicone ones, but they all have a role. So which of the following treatments is least effective for aqueous dry eye disease? Restasis, Cequa, Xiidra, or Lipoflow? Well, Restasis, Cequa, and Xiidra are all similar medicines. So those are all good for aqueous deficiency. Lipoflow, not as much. When we talk about treating evaporative dry eye disease, warm compresses, vitamins can help. Oral vitamins like flaxseed oil and omegas can help. Topical Isosite was something that was pushed a while ago. It's not used as much anymore, but it helps the meibomian glands work a little better. Oral doxycycline works great, but can cause an upset stomach. Dermatologists use it to improve skin, and we use it to improve the glands in the eye. And then there's meibomian gland expression, where you can actually squeeze out some meibomian gland blockages, and that helps certain patients do better. Lipoflow is basically a super warm compress that squeezes the glands out. You can see how happy this patient is to get Lipoflow. She's smiling. It's basically some heat that's applied to both the anterior and posterior surface of the lids while the machine massages you. Then there are alternative treatments, which is anatomical corrections, fix the lids if the lids are a problem. Conjunctivoplasty, if there's too much conjunctiva that's rolling around, snip a little bit off. Hormone therapies can be helpful. Steroids can be helpful. So there are really a lot of different treatments out there that are useful for patients. And don't let them get discouraged if they've tried something and it hasn't worked before. We're just maybe not figuring out what the real etiology in this particular patient is. But usually with trial and error, with educated guessing, you can try and figure out what works. So hope this helped, and it was a pleasure to see all of you.
Thank you so much, Dr. Winnicott, for giving that talk. As a retina guy, I think I'm going to have nightmares about those meibomian glands you showed. That was scary. What do you do for that? Because I've seen that, and these people are miserable. Is it warm compresses? Is it?
Yeah, I wish I could say warm compresses were enough, but they're not. I mean, it helps, you know. I used to work with someone, I used to call it Mickey Mouse, you know. It's like, yeah, put a warm towel on it. It's like, really? That's going to be, I came to you to tell me to put a warm towel on it. But basically what you could do, you can squeeze it out in the office and help kind of clear out the bad stuff. And then you really got to change their dietary habits. You got to have them, omega helps, flax helps. Doxycycline really does help. You have to be on it for a while. You know, and that's going to cause an upset stomach, but I've had patients on it for months or years and they love it and it works well. So it's a battle because you're not really curing these patients. You know, it's like arthritis. You're going to treat them. It's going to get a little better and then it's going to get a little worse, but you work on it.
When they ask, well, how much flaxseed should I take, or flaxseed oil, or
so usually what I say is if you're doing the raw flax, it's going to be 3,000 milligrams a day of flax. So if you go to the vitamin store and you're just buying flax, you're sprinkling on your cereal 3,000 milligrams a day. If you go to the pharmacy, you'll see that they sell vitamins for dry eye. And if you look at the ingredients, it's flaxseed oil. And usually it has about 1,000 milligrams a day in those formulations, but they're packaged with other things that enhance the absorption. So they can handle 1,000, but they're absorbing it better. So either of those work.
Wonderful. Well, I really enjoyed that talk. Thank you so much for your time this afternoon. I hope we can have you back sometime. Our next speaker is Patrick Cody. Dr. Cody did his ophthalmology residency at California Pacific Medical Center in San Francisco, and he completed his vitreoretinal training at Yale School of Medicine. He's now practicing at New England Retina Associates with offices in Hamden, Trumbull, Westport, and Old Greenwich. He's also an attending ophthalmologist at the VA Connecticut Healthcare System in West Haven, and he's assistant clinical professor at Yale School of Medicine. I've enjoyed working with Dr. Cody over the years. He's a great guy, good to have in the retina community. He's going to talk to us about vitreoretinal surgery, which is amazing that he's going to fit this in half an hour, but he's going to talk to us about different types of vitreoretinal surgery and what you can expect to see as a technician in this talk titled Overview of Vitreoretinal Surgery. Dr. Cody.
Thanks, Dr. Lin. Thanks for inviting me. Pleasure to be here. I've been enjoying the talk so far during this meeting. That nasal stimulator, I guess during the era of COVID, you can't share those among people. So that's just a cautionary thing from the previous talk. But I can't fit in everything about vitreoretinal surgery. I do post cases. I've been a little slack in the last month, being a new father of a second kid this month. But I do post cases on Instagram if that's pertinent to retina topics that we see in our clinic. So, you know, you're all eye professionals. Some, I'm going to be showing videos, so hopefully that comes across clearly for you. So if there's, you know, kids or other people around, some may be considered a little bit more graphic. Instead of kind of going through my questions word for word that I posted, I'll be trying to highlight in yellow some of the, you know, the answers and of the topics that I put out there. So we can't you know, cover the full breadth of vitreoretinal surgery, but I just wanted to give you, my main goal is to kind of give you a glimpse of what we see when we're in the OR, behind the microscope. The folks listening to this presentation are hard at work taking care of patients, but not necessarily seeing exactly, you know, what happened to the patient when they show up for their post-op day one, post-op week one appointment. So just want to give you a little flavor of what it looks like when we're performing some of these. So we'll talk about rhegmatogenous retinal detachment repair, some macular disease surgery, some surgery related to problems or complications from cataract surgery. And then we'll talk about, if we have time, some surgical intervention related to macular degeneration. So this is one of our questions here. So there's different types. When we talk about retinal detachment, we use it as a shorthand to talk about, primarily, we're talking about rhegmatogenous retinal detachment, which is the type of retinal detachment you get from a tear in the retina, and subretinal fluid is able to get underneath that tear. And the retina detaches that way from a mechanical means. Exudative retinal detachment is more in the lines of when we're talking about posterior uveitis or central serous retinopathy or other diseases where you can have leaking of fluid underneath the retina, not caused by a break in the retina. And then tractional detachment, most commonly seen in our diabetic patients from scarred tissue pulling off the retina. And there can be a mixture in the types of retinal detachment, but in general, when we use retinal detachment in shorthand, we're talking about rhegmatogenous retinal detachment. So this case is just to illustrate that not all cases of retinal detachment ends up in the operating room. This was a 55-year-old female patient that presented in my office 4 years prior with asymptomatic inferior retinal detachment in actually both eyes, and she had a laser barricade you can see in the right eye for basically 360 degrees, and in the left eye as well, infratemporally. And this was just taken a couple months ago. So this would be a laser barricade for treatment of retinal detachment, but we're going to focus on cases that are more surgical. So this was another patient of mine, 85-year-old lady who came in with 1 week of vision loss in the right eye. She had hand motion vision. And you can see in this Optos photo of the right eye, you can see the retinal detachment, unfortunately, including the macula. You can see kind of the water line over here, and the OCT shows you the fluid underneath the retina, and you could see the break here. This was the only break we found on exam. So we have a rhegmatogenous retinal detachment with a break at about 9:30 or 10 o'clock. So we discussed the options with her. And so just to kind of review our options here. So we have pneumatic retinopexy, which is an in-office procedure, pars plana vitrectomy, and scleral buckle. So those are the three surgical options we're going to talk about. So after discussing all the options, she elected for pneumatic retinopexy, which is a procedure we do in the office where we do a freezing treatment to the break and inject a gas bubble, have the patient position usually face down for the first day or two, and then position with the gas bubble overlying the break so that the freezing treatment, or you can also do laser barricade the next day so that seals down. And this was her OCT picture 2 weeks later. From hand motion to 20/50 vision. And I've seen her more recently than that. Vision is trending towards 20/40. But you can see initially, she had a macula off retinal detachment. So her visual prognosis, we expect good recovery in her vision, but these patients can get close to what they were before retinal detachment, but they never quite get back to what their vision was before the retina detached in the first place, and unfortunately involved the macula. So here on this Optos picture is a little bit of a montage picture. You could see the gas bubble at 2 weeks that we injected, almost gone. So as I mentioned, this is kind of one of our in-office retinal surgeries, pneumatic retinopexy. This is one from the original paper in 1986, which described this procedure. You can see there's different ways to do this and you can stage it, but the way this described here is cryotherapy to the retina breaks, followed by injecting a gas bubble, and then positioning the patient so that the gas bubble pushes the retina back, and so that the cryotherapy can seal the break once the gas bubble dissolves. So just a general rule of thumb, so candidate for pneumatic retinopexy is, in general, again, this is kind of generalizations, and there's other nuances that we're not going to get into, but retinal detachment with few breaks and generally close together, and superior, meaning in the kind of top 2/3 of the clock hours of the retina. So in general, if it fits that criteria, this is a procedure that can be considered if the patient can position for it. There's different ways, like I said, to treat the breaks. You can treat the breaks with cryotherapy, or you can treat the break on a subsequent day with laser barricade once the gas bubble has pushed the retina back into place. In general, if you compare laser with cryotherapy for treating a retina break or tear, in general, laser has some advantageous properties in that you get normal adhesion much quicker, where within a day, and then you get a 2 to 3 times normal seal. Twice normal seal at about 2 to 3 weeks, whereas cryotherapy, actually initially even up to the first week, because of the edema and the swelling from the cryotherapy, the seal can actually be weaker before it starts to firm up. And there's other theoretical advantages to laser, in that it being less inflammatory, but cryotherapy is a good option. The different type of gases, there's really 2 gases available in the United States. In Europe, there's 3, but for those that work with retina doctors, SF6 and C3F8 is a very common parlance. So C3F8 is a much longer acting gas. It can last in the eye up to 3 months, whereas SF6 can last up to about 5 weeks. So the main precaution that, we always have to think about, the thing that's going to blind the patient, is that this gas bubble can expand with 2 major things that they wore a safety bracelet for. One is if they get nitrous oxide anesthesia, and the other is air travel. So the change in air pressure from sea level to about whatever the cabin pressure is pressurized to, usually about 8,000 feet or higher, that can expand the gas bubble, which doesn't have room to expand because the eye is a closed space, so the intraocular pressure can raise to a dangerous level. So this is something we got to always be vigilant that our patients understand that when we treat. So in general, with pneumatic retinopexy, there's about maybe a 20% chance of needing additional surgery and other associated complications, but it's a good option for the right patient in that you don't need the operating room time, and in general, less use of resource for our healthcare system, and potential savings. It also has been handy during this time of COVID, when perhaps operating room time, not that we don't have operating room time, but getting patient COVID tested and the lag associated with that, this is a procedure you can get done right in the office. So it is generally less invasive than surgery, but it does also have a lower first-time success rate compared to the other options, which we'll talk about here. This was an 80-year-old male who had vision loss in the left eye for 2 days, preceded by new flashes and floaters. This is my drawing of the left eye. He had a macula off retinal detachment with multiple breaks, including breaks, in the lower 1/3 of the retina. He had a history of multiple tears in the other eyes that were treated. So let me show you this video. If there's any problem with this displaying, please let me know. So this is, I'm just going to pause here off and on. So this is our 3-port vitrectomy system. This is a pseudophakic eye. You can see the intraocular lens here and the glimmer of that. We have 1 port that provides infusion, and then 2 ports, generally one for instrumentation, the vitrectomy tip, and the other one for lighting. So this is our vitrectomy tip. It's like a guillotine that cuts back and forth, and the cut rates have gone up a lot. Cut rates are anywhere from about 5,000 to 10,000 cuts per minute. And the reason that's important is because the vitreous is attached to the retina. And what you're doing is cutting a small piece, vacuuming it, vacuuming it, so that you can gently remove the retina without tearing more. Gently remove the vitreous without tearing more retina. Here in this video, you could see a break that we're highlighting with diathermy, which is a type of cautery inside the eye. This is another horseshoe tear. And this is scleral depression here, where we're indenting the eye to clean up the vitreous. And then this is what we call fluid air exchange, where we're putting air into the vitreous cavity and removing the subretinal fluid through one of the existing breaks. And so now the retina is flat by the air that we've placed. We laser all the breaks that we marked with diathermy, make sure the vitreous is dry, and we exchange that air with one of those gases, either SF6 or CH3F8 gas. And this is what it looks like at the end of the case with our antibiotics and steroid injection at the end. So this patient with 3.5 months after surgery, again, macula off, retinal detachment. So we don't expect vision, unfortunately, going back to 2020, but regained vision to 20/60 vision. And you can see a big improvement in the OCT and starting to reconstitute the outer segments of the OCT, which for our mind tells us that the photoreceptors are starting to get organized and function better. So that was a case of we've seen so far of a pneumatic retinopexy. First case, second case was primary vitrectomy. And our nomenclature here, you'll see this PPV means pars plana vitrectomy. Fluid air exchange was the part of the surgery I showed you where we took the fluid out of the vitreous cavity and put air to flatten the retina while draining the subretinal fluid, and then SF6 gas, which is what we exchanged the air for at the very end of the case. This patient positioned face down for a week, and the gas bubble, since it was SF6 gas, was gone in about 3 weeks. Another case, this was a 56-year-old male who presented with hand motion vision, count fingers vision for 3 to 5 days in the right eye. He was noted to have a giant retinal tear, and a giant retinal tear is a retina tear that covers more than 3 clock hours, so more than a quarter of the circumference of the retina. So let me show you what that looks like here. So again, this is our 3-port vitrectomy system here. This is me putting in the ports. And here, it's a little bit of a hazy view, but you can kind of vaguely make out the optic nerve. But what's interesting is that the retina is flopped over the macula and the optic nerve. It's such a giant tear that the retina is flipped over, covering the macula and optic nerve. So here we are taking a peek underneath. This is the back side of the retina, and here we see our macula and optic nerve here. So in these cases, we need a little extra help to unfurl the retina open. This fluid that we're injecting into the eye is called PFO, which is perfluoron, which is a heavy liquid that we inject to flatten and steamroll the retina in real time during the surgery. Because otherwise, just putting air, the retina will stay kind of flipped over onto the macula. So here we have, we're doing scleral depression, indenting the eye, removing the vitreous carefully, removing even anterior parts of retina that are left over, which can be nidus for PVR. That was showing removing some anterior retina, and then under the PFO, putting laser. This is an extensive area that we have to laser for almost, this was more than 180-degree tear. So more than half the retina was torn. That's why it was flopped over and covering the macula. And you could see the backside of the retina. We removed that PFO liquid. It can't stay in the eye, and we put air to exchange, and then we exchange that air for a long-acting gas. And this is what it looks like at the end of the case after we've sutured our wounds. So 7 months later, you see that you've lost the foveal contour. This unfortunately is not an OCT exactly through the fovea, but if you take a OCT through the fovea, you've lost some contour. There is a little bit of ERM and scar tissue, but in generally, this patient did very well, 20/50 vision, and also with posterior capsular opacity. So had even improvement in vision after that to about 20/30, 20/40 vision. I want to show you another case. This will be kind of like our last in the section for retinal detachment, a 40-year-old female who had vision loss for at least 2 to 3 months prior. The reason she presented so late after losing vision is a couple of things. One is she had poor baseline vision from amblyopia in that right eye, and she was mostly relying on her left eye for most of her life. And second thing, because of COVID, she was scared to kind of get seen. So this was a case where we did a vitrectomy, but we also put a scleral buckle. I don't have a case of a primary scleral buckle, which means just doing a scleral buckle without vitrectomy. But in general, scleral buckle is a silicone band that supports the vitreous base, and you want to position them so that the brakes are mounted on the buckle so that it changes the fluidics in the eye so fluid can't get underneath the retina anymore. This is kind of a cartoon of what that looks like. So again, this is the 3-port vitrectomy system. The only thing that's different is here you can see our loops around the rectus muscle. You see the retinal detachment here. We're doing our vitrectomy. You can see the vitreous kind of fluttering as we're cutting it. This was a nice case because you could see what the buckle looks like. We started the case by putting the scleral buckle on first. So this is what it looks like during the surgery. We're tightening it to give us some indentation at the time of surgery. Here you can see the indentation. And that indentation, instead of me doing my own scleral depression or assistant doing that, provides us with our own scleral depression so we can clean the vitreous nicely 360 degrees. This patient actually had a dialysis type tear, which is a tear in the most peripheral location. Again, this is PFO liquid flattening the retina. And we ended up, this is us lasering the dialysis and doing a fluid air exchange, putting air in the vitreous cavity. And then we actually ended up putting oil in this eye. And this is what it looks like with the oil coming in. So the oil, instead of a gas, has to be removed at a further date. Here you can see the oil filling the vitreous cavity, and the sclerotomy sites were sutured, the scleral buckle trimmed, the peritomy that was made in the beginning closed, and this is what it looks like at the end of the case. So potential drawbacks of scleral buckle is, there could be short and long-term complications associated with it, including diplopia or extrusion either in the near term or late term. And they could cause issues with intraocular pressure by impeding scleral outflow again. I'm going to skip this just in the interest of time and talk about a couple macular disease cases. So this was a 72-year-old man who presented with distortion of his right eye vision for 2 months. He had 20/60 vision, but was a lawyer, prolific reader, and wanted to have some something done about it. After discussing the risks and benefits, he decided to have vitrectomy with macular pucker. So macular pucker, the thing that you need to know is that the most common complaint in patients is metamorphopsia or distortion of vision. So that's one of the answers to the questions there. So again, this is a 3-port vitrectomy system. We are putting our, this is a phakic patient, so they haven't had cataract surgery yet. So you put the ports different location based on whether they've had cataract surgery before. We start off the same way, doing a vitrectomy, removing the vitreous, cleaning up some of the vitreous in the periphery. Then this is a stain we use to stain the ILM, that's called ICG stain, and this is washing it out. It helps us see the interface between the macular pucker and the ILM so that we can peel it. Sorry that it's a little bit blurry here. Hopefully not too bad on your screen. And then we manually try to find an edge and peel. This is kind of like a real time here, not real time, but so thankfully we've caught an edge of the macular pucker, and this one was fortunate in that it came off in a nice sheet. But this is what it looks like at the time of surgery, peeling off that membrane from the surface of the retina. So then usually we finish off the case by inspecting the peripheral retina, making sure there's no tears, and then closing up our wounds, make sure everything is watertight. So this patient did well. This was 4.5 months. With macular pucker surgery, the improvement is not immediate, it's gradual. And most of the improvement is up to 3 months in the distortion, but can be improvement 6 months to even a year after surgery. I will skip this case and talk about full thickness macular holes. So this was a lady who had a distortion in vision in the right eye from a full thickness macular hole. You can see in her left eye, she started to have Vitromacular Traction and then stage 1 macular hole. And she decided to go for vitrectomy for repair with membrane peel in the right eye. And her vision improved at 1 week to 20/40 and then 20/30. Her left eye subsequently, that Vitromacular Traction and stage 1 hole improved spontaneously without surgery. So I had a typo on one of my questions, question 4, regarding, it's supposed to say regarding full thickness macular hole, not full thickness retinal detachment. So what's pertinent there is that, as I showed you in that case, half of the stage 1 holes can actually close spontaneously. But if you have a stage 2 hole or higher, nearly 100% of those progress with further deterioration in vision. Okay, last thing we'll talk about is dislocated lenses. So this is after cataract surgery, could be many years after cataract surgery, the intraocular lens dislocating into the vitreous cavity. And there's different options for that. You can exchange that lens for different type of lenses. But the thing to be aware of is that the most common cause of dislocation is pseudoexfoliation syndrome being the most common risk factor with more than 50% of cases. But other causes are significant, like aging, trauma, or diabetes, or interestingly, retinitis pigmentosa. So this is the technique I usually perform to fix this. So this was a late 90s female who had a dislocated lens in the left eye. Let me just show you, this will be our last video here. So here you can see the dislocated intraocular lens sitting on the back of the eye, sitting on the retina. I start off with a 3-port vitrectomy, and we're grabbing the lens complex. You could see the capsule still there and soldering ring. We're grabbing it with our MST instruments with viscoelastic, placing it into the anterior chamber, cutting it in half so we can still remove this old lens through a small incision. as well as the old cortical debris. We use plenty of viscoelastic during this procedure. This is our new 3-piece lens going into the sulcus. And since we don't have any capsule support, we have to find we have to fixate that. And as I kind of glossed over, there's different ways to do that, but this is a scleral fixation technique where we, using a fine tip needle, we thread the haptics into the needle to externalize the haptic and fixate the lens to the sclera. So this is threading the haptic inside the eye on one side, and then the trailing haptic on the other. And then we're going to externalize that. And then the trick to this is once we've externalized these haptics, we cauterize the tip of the bolt so that they can't slide back into the eye. We tuck the haptic underneath the conjunctiva and sclera. Here we can see that intraocular lens. You can see one of the haptic, but once this pupil comes down, that's going to be nicely in the visual axis. Hydrate our wounds and make sure our scleral wounds are watertight. So it's a large topic, but I hope I gave you a flavor of what's involved in vitreoretinal surgery. I just want to thank Deb for putting this meeting together, Dr. Lim for inviting me, and then my team at New England Retina at the VA for this is a team sport. So thanks for everyone's effort in taking care of these patients.
Thank you, Dr. Cody. Great talk, great videos, really showing some of the cutting edge stuff that you do. So thank you again for spending some time with us this afternoon. Our next speaker is Mark Russi. Dr. Russi is a professor of medicine at the Yale Medical School, and he earned his medical degree from the University of California at San Francisco and his public health degree from Yale. He completed both internal medicine residency and occupational and environmental medicine fellowship at Yale and joined the faculty in 1993. He's active both nationally in guidance, development, and educational programs to enhance the safety of medical center. He attends on the internal medicine inpatient service, and he directs the occupational health services at Yale New Haven Hospital. He's going to speak with us regarding COVID-19 in his talk titled COVID Vaccination, Treatment, Prevention, and Transmission in the Office Setting. Thank you, Dr. Russi, for joining us again today.
Thanks very much. And Dr. Rick Martinello is going to join me. Rick is an associate professor of medicine and pediatrics and our medical director for infection prevention. And we'll go through these things fairly quickly. I know the time is limited. So next slide, please. Rick, are you able to? Great. So just rough statistics as of Tuesday, about 62 million cases of COVID to date in the US, with unfortunately 839,000 deaths. The actual cases may even be higher than that. If you look at that amount of mortality and apply what many regard as a reasonable estimate of the mortality rate, about 0.6 to 1.2%, it may be that the actual number of cases is closer to in the range of 70 to 140 million. And more recently, with the lower mortality of Omicron, the actual case counts could even be higher than that. The Connecticut data, a little over 600,000 cases, 9,300 deaths. I don't want to go into too much detail about the last 2 years, but maybe just to mention a couple of things. Obviously, all kinds of infrastructure didn't used to exist that we had to set up in order to do testing of hundreds of thousands of people and field calls from hundreds of thousands of people, the mass vaccination efforts. We've had to toggle between containment phase, where you regard COVID exposures as sort of the exception and an event that requires contact tracing, et cetera, versus mitigation phase, where we're just swimming in COVID and we regard exposures as happening just about all the time, whether or not we're aware of them. And we dispense with things like detailed contact tracing in that mode. And that's kind of the mode we're in right now. We've had to pay attention to the guidance for the last couple of years as it has changed. And as everyone knows, often those changes have been pretty rapid. We have tended to err a little bit on the side of caution. We maintain folks in respirators throughout this, even though there was guidance for a while that you could treat COVID patients wearing just face masks. We've also tended to be a little bit more conservative, including now. We could be doing contingency guidance of allowing healthcare workers to come back on day 6 after they've had COVID without a test. We're not doing that, and that's partly based on some data that are beginning to accrue that let us know that it probably isn't safe to bring folks back at day 5 or 6 yet. They could still be spilling virus. So we have done our best to try to err on the side of caution. Next slide. The vaccination effort, about 62% of the US population have been vaccinated. About 70 million have also been boosted, and nearly 75% have received at least 1 dose. Fortunately, in the older age group, those numbers are a little bit higher, as you can see there. In Connecticut, we are now at about 75% of the population, and 90% of folks in Connecticut have received at least 1 dose. Obviously, there are challenges to get everyone vaccinated. There are folks who are sort of still holding out. The anti-vaxxers have done a great job of spreading all kinds of misinformation, but basically, this is a very good vaccine. I can show you just a little bit of data. Actually, next slide, please, Rick. So this is actually from the state of Connecticut, and what this shows is that a vaccinated person is 3 times less likely to become infected with COVID. But the next slide really is probably the more important one. If we can go to that one, that actually shows that an individual who is not vaccinated is 17 times more likely to die from COVID than an individual who is vaccinated. A 17-fold difference is really quite dramatic, and it speaks to how effective the vaccine continues to be, even against Omicron, in preventing severe outcomes. As you know, it's not quite as effective against Omicron as it has been against other variants in terms of reducing transmission of disease. But for the individual who is vaccinated, this is a vaccine that is still extremely protective, both from death from COVID and also hospitalization. There's about a 12-fold lower rate of hospitalization in Connecticut among people who have been vaccinated versus those who haven't. Next slide. These are just some numbers from our own health system. If you look at the blue line down there, you can essentially see the 4 waves of COVID beginning all the way over on the left-hand side back in March and April of 2020. And the encouraging news in the last few days, we are finally beginning to see this spike come down a little bit in terms of inpatient hospitalization. So we will continue to be hopeful there, and we'll see what happens. Next slide. This just shows admissions themselves, and you can see how the admissions during this wave have really dwarfed everything that came before. Next slide. The case for boosters is a strong one. At first, the data, there was some controversy. Does this really make sense? But there have subsequently been studies that show quite clearly that the boosting is necessary. The first really good one was reported in the New England Journal in early October, and it was based on the Israeli experience of giving the 3rd booster to folks over the age of 60, and it showed that they were 11 times less likely to become infected than those who weren't boosted, and 20 times less likely to have severe disease than those who were not boosted. And there has been subsequent work that continues to show that, and the boosting is particularly important now with Omicron at 95% across the state. Next slide, please. So we've had a mandate in place for a while. There's a lot of controversy when mandates around flu vaccination were first put in place. I think that the case for mandates with this vaccine and this disease has been actually much stronger. It's a more deadly disease. It spreads more easily. There is more there's a higher proportion of individuals who cannot have symptoms and can hence spread it to other people. So vaccination really has been so important, and particularly in healthcare. The consensus across the country is that mandates have been justified. And we will now have a booster mandate in place as well. So lots about Omicron in the press. What you have heard is that this is a virus that seems to spread more easily, seems to cause slightly milder disease. We don't know exactly why it is that it spreads more efficiently in populations. It may be that the most important element there is just its ability to escape immune protections. As you probably have heard, there are like 36 different mutations of the spike protein. So really a very different virus from what we've seen before. We don't know whether there's more virus released by infected individuals here. The data have been a little bit conflicting on that. We, in general, don't think this is a virus that transmits over very long distances, though there have been a couple of exceptions to that to date, one in particular from Hong Kong. Things happen faster with this virus. The incubation is quicker. It's more like 3 days versus 5 days for the other variants. There is, by the way, a CME question. There are two of them I want to warn you about. And one asks the incubation period. It's an old question from the Delta era. It says 5 to 6 days. The current incubation is 3 to 4 days. If you mark 5 to 6 days, that is fine. That's the old, that's based on Delta. There's another rather arcane question about the specific Delta clave. It's AY25. You will never need to know that, but that's the answer to the question. When you see that, just remember AY25. So another important difference with Omicron is that it has a little bit more of a predilection for the upper part of the respiratory tract, the bronchial tubes, rather than the deep lung. That's good because people don't get as severely ill in respiratory distress. But it may also enhance transmissibility with folks potentially more efficiently coughing from the bronchi than from the deep lung. We don't know whether there's a lower infectious dose that's required for people to get infected. We certainly know that it causes milder disease, which of course may predispose to there being more asymptomatic people who think they're perfectly healthy going social mixing with others. And that of course also can enhance transmissibility in the population. Next slide. Lots of stuff that's happened over the past couple of years may find its way into guidance going forward. We've learned the value of social distancing and masking. It certainly prevented flu from getting any foothold in the human population last year. Flu is not having a banner year this year. It's doing better than it did last year, but the impact on flu certainly speaks to the utility of masking, and it may be that going forward that we will see more masking in general in healthcare settings than has been in practice in the past. Next slide. I think this is the last one, and it's really just sort of the transition toward endemicity. And important to bear in mind that endemicity does not equal benignity. As this virus becomes more just present in the human population, we hope that it will be milder. We hope that Omicron's the first step in that direction. But we do have endemic diseases that nonetheless cause a certain amount of mortality every year, and that may be the circumstance with COVID. So I'm going to hand the podium over to my colleague, Dr. Martinello.
Thank you, Dr. Russi. So in the few minutes that we have remaining, I just wanted to go through a few additional slides, both about Omicron and really about a little bit more about how we prevent transmission in the office setting. This slide shows the rise of Omicron here in Connecticut, and this is data from Yale New Haven Hospital, where you see Omicron represented in the blue bars and the Delta virus in the gray bars. And right now we're seeing about 95% both in our hospital and our ambulatory settings of COVID being due to Omicron. here's some predictions going out about 4 weeks from the CDC. And these were the latest data from them is from January 3rd. And so this is really looking at the remainder of January. On the left-hand panel, you can see what they're predicting for hospitalizations per day for the remainder of the month. And you can see that we're expecting there to be a continued increase. Here in Connecticut, on the right-hand panel, seem to be doing a little bit better than that. And perhaps it's because we have such a highly vaccinated population, and our population is really perhaps a little more compliant with masks and other measures than we see in other states. But you could see a little bit more of a plateau and a decrease as in hospitalizations each day as the month goes on. I've tried to capture the vaccine recommendations as they currently stand. And as we know, vaccine is now recommended for all persons aged 5 and older. And boosters are recommended for all persons aged 12 and over. There is a recommendation for a booster for those between 5 and 11 years of age, but that's only for those who are significantly immunocompromised. And for the younger kids, I'll just note that we're still primarily using the Pfizer vaccine because that's really where most of the data is for that age population. It's very important to think about the effectiveness of the vaccine. And we are very thankful that this has been just an amazing vaccine with how well it works. And when we think about this from an infectious disease standpoint, we typically think of how well does this vaccine do to prevent people from getting infected. And we know that's where we've seen some decrease in individuals with time after they've been vaccinated, but also with the Omicron variant, a little bit of a decrease of how well those vaccines work. But what we find is that the vaccines continue to be extremely effective in preventing severe disease and preventing hospitalization and death, even with a little bit of time and even with the Omicron variant. And so these are just really outstanding vaccines. And I think now looking at them and comparing them with other vaccines, these are probably the best studied vaccines that we routinely use now. So there's just been an enormous amount of resources put into investigating these vaccines, not only with how well they work, but also for vaccine safety. And so that really does, as Dr. Rusi was saying, between the effectiveness of the vaccine, in particular to how it prevents severe disease, hospitalization, and death, in addition to its outstanding safety record, that truly does help to support our moving forward with vaccine mandates. There are some new medications that are available to treat patients and prevent COVID. And on the left-hand panels, what I show you are the two new oral antivirals that are in use. One is known as Molnupiravir, and the other is Paxlovid. The use of these medications are a bit complicated. With Molnupiravir, while we do not have any evidence suggesting harm to unborn children because of theoretic concerns because of how the drug works. We do try to avoid use of this medication in women who are pregnant and also among men who are trying to conceive a child. Now, that said, these are just theoretic concerns that with all the testing to date have not been borne out. However, because of that, if there are not other treatment options, it requires a physician and the patient to have some shared decision-making to determine if it's in their best interest to use this medication, particularly because we know COVID can be so devastating during pregnancy. For those who aren't pregnant, this is actually a very easy drug to use, and it does show good effectiveness. Paxlovid shows very high effectiveness in preventing hospitalization and death. And it's a very well tolerated medication, but one consideration for those prescribing it is it's a combination medication of a protease inhibitor plus ritonavir. And that ritonavir has a number of drug-drug interactions, and it's very important for the prescribing physician just to be aware of those and make sure that the patient they're thinking of prescribing Paxlovid for is not taking any of those medications. two monoclonal antibodies that are now available. One is called Evusheld, and this is actually for preventing COVID in those who are at high risk for severe disease and who have not been able to get fully vaccinated and boosted. And the other one that we're using is Sotrovimab. Sotrovimab is a monoclonal antibody that we are using for the treatment of COVID. All of these medications right now, each of these four, are very scarce. And so we're really focusing their use for our high-risk patients, those who are at high risk to develop complications from COVID. Isolation, this is how we isolate patients. It's a little bit complex, but let me try to make this as simple as possible. What we're recommending in Yale New Haven Health is that for our general public patients, ones who don't need to come in to healthcare, we're recommending what the CDC does. 5 days of isolation followed by 5 days of very cautious masking. For our staff, because as Dr. Rusi was saying, we're seeing contagiousness sometimes extending a little past 5 days. We're requiring 7 days of being out away from work. And for our patient population, because our patients oftentimes have many underlying illnesses, and we're concerned about them being around our other patients, having close contact with our staff, we do require 10 days of isolation for our patients, and that's both in the office setting in addition to the hospital setting. Quarantine is used when we have somebody who is exposed to COVID, but not yet ill, so they're still doing well. There's some differences based upon if somebody is up to date with their vaccination, which now includes boosters, and whether or not they work in healthcare. For the general public, if they are up to date on their vaccinations, including their booster, we don't require any quarantine, and we guide them toward just getting tested again at 5 days. But if they have not received their boosters, we're asking that they quarantine for those 5 days in addition to getting tested. For healthcare personnel, if they are asymptomatic, regardless of their vaccination status, we allow them to work. But if they haven't received that booster, we do ask that they get tested twice in the Yale New Haven Health System, once around day 1 and 2, and then again around day 5 to 7 after their last exposure. And finally, a little bit about what we do to help protect our staff. I think one of the take-home messages is from this is it's not all about personal protective equipment. These are all of the different interventions that we have to really protect our staff and keep people safe. And that includes the use of a mask at all times, the use of eye protection, and then if we are interacting with somebody who we think may be contagious, using a respirator in addition. And I'll go ahead and end there and hand it back over to Dr. Lim.
Thank you so much, Dr. Rusi and Dr. Martinello, for joining us this afternoon. I'm sorry, in the interest of time, I'm going to just keep this moving. If people have questions, they can submit them to us, and we'll make sure that we get answers back from Dr. Rusi and Dr. Martinello. Thank you again for your time this afternoon. Our next did his residency at the Albert Einstein College of Medicine and got his master's degree in public health and epidemiology from the Johns Hopkins School of Hygiene and Public Health, and fellowship training in glaucoma at Duke University. He also did fellowships in international ophthalmology at Bethesda and Baylor, and preventive ophthalmology at the Wilmer Eye Institute at Johns Hopkins. He has a wide experience teaching, and he's been fighting blindness worldwide through Orbis International. He's associate professor of clinical ophthalmology at the Yale School of Medicine, and he's our current president of the Connecticut Society of Eye Physicians and one of the major influencers bringing this program to you today. He's going to talk today about factors that can contribute to glaucoma incidence or progression and describe visual field changes that might suggest that one of these other factors is in play. He's going to do this in his talk titled The Other Side of Glaucoma. Welcome, Dr. Martone.
So, hello, everyone. Been a long day for you. I'll try to get through this and not keep you too long. So I just named this The Other Side of Glaucoma just because so often when we think of glaucoma, we just think of pressure. And even with working with the residents and so forth, even when we know that the main cause of the glaucoma is something other than the pressure, we tend to still focus on what the pressure is. So I wanted to do something here today to highlight the other parts. I have no financial disclosures. So just to start out, a review of the optic nerve head. Can you see my cursor?
Yes.
Okay, good. All right, so the optic nerve head, there's the superficial nerve fiber, there's the prelaminar area, there's the lamina cribrosa, all right, and the retrolaminar area. So what you notice here, it's really one of the most multifactorial eye diseases because it includes so many different things. So you have nerve tissue, you have connective tissue, you have vascular tissue, all in this little area. You even have cerebral spinal fluid coming up from behind and can nourish this, but also compress it or create a negative pressure. So if we look at all these things together, glaucoma really is a very, very multifactorial condition. Here's another view of it in another way, okay? And you see the main blood supply comes from the short posterior ciliaries. There's a little circle of Zinn that goes all the way around at the nerve head here. There is also these Peel arteries that penetrate into the nerve and give nourishment back here. So it's a really rich nerve supply, but it's also at risk. So if we just consider intraocular pressure first, everyone knows about that. The higher the pressure, the greater the risk. The longer the duration of the pressure, the greater the risk. The more it fluctuates, there's evidence there's greater risk. And as a single risk factor, so I'm just going to go on a slide. I'll forget my cursor. So what part of the nerve is most vulnerable to getting damage? You can see on the right side here, there are different areas of the nerve. The top right, the big fibers that come in from the periphery don't have a lot of scleral support. So the pressure in the eye is going to damage that area more. Just below that is the papillomacular bundle, which serves the macula. Those are not as susceptible to pressure, but more susceptible to vascular insults. So here's what it looks like if you have a vascular issue. I mean, if you have a pressure issue, the superior and inferior part of the nerve. So where do those fibers come from? They come from the periphery. They're hooked up to several hundred photoreceptors, come in as big fibers, less scleral support, more commonly get damaged by pressure. And the visual field you get down below is more of a nasal field. Now, what are the other? So the other side of glaucoma, all the other things that can impact it, and they're usually ischemic in nature. Low systemic blood pressure, especially diastolic, because we've become more aggressive at lowering blood pressure as we've gone along over the years. Arterial stenosis, older people have stenotic vessels. Faulty autoregulation. So with migraine, Raynaud's disease, sleep apnea, you get poor autoregulation. So you get more blood flow when you don't need it and not enough when you do need it. So that's a problem with the optic nerve. Ineffective cardiac function like arrhythmias, heart failure. So an EKG will help us to understand if there is an arrhythmia which is causing a problem with us. Poor oxygen saturation is a problem. So now if you have narrowed vessels or arrhythmias, and then you add poor oxygen saturation to that mix with sleep apnea or anemia, that adds to the risk. Sleep position can make a difference because when you're lying flat, the venous drainage from your eye is poor, so the pressure's higher. So now if your blood pressure drops at night and your eye pressure's higher, then you have a poor perfusion pressure, and that adds to the problem. Dr. Higginbotham this morning talked about central corneal thickness, which gives you a falsely low pressure reading in the eye. But I think the bigger issue with that is it tells you if you have a thin cornea, you probably have a thin eye wall, which means you probably have a thin lamina cribrosa, which may be more vulnerable to pressure changes. Tissue type is another thing, but we have never really gotten into that too much. But there are certain people who have different types of tissue that are more susceptible to causing distension and damage. Cerebrospinal fluid pressure, if you have too low of a cerebrospinal fluid pressure, it doesn't properly support the optic nerve head. Glaucoma then can happen easier. Conversely, if you have high cerebrospinal fluid pressure, you get you get papilledema, which is, in essence is reverse glaucoma. It causes pressure on the nerve head and causes nasal defects, which are in fact like reverse glaucoma. Autoimmune conditions can also cause glaucomatous changes, either because we're cross-reacting with a bacteria in our body, or there is a immune cascade that is started from the damage of glaucoma. That's beyond the scope of this talk, but it is something else that can happen. So the area that gets damaged is the papillomacular bundle, which serves the center of your vision. Now, these fibers are much smaller and they're tightly packed, and they serve a small number of photoreceptors because this is high definition vision. Small axons, tightly packed, less room for capillary support. So if there's less room for capillary support, they're going to be more vulnerable if there's a vascular insult. The damage results then in paracentral scotomas. And again, here you see the larger openings at the upper part of the lamina. Temporally there on the left, on the right side, you see small axons going through there. In the center of the nerve, there's really nothing going through there. So here's asymmetric glaucoma. On the left eye, you see a paracentral defect. And whenever you see that, you have to think, okay, this isn't just pressure, this is a vascular insult. The other clue to that on the bottom picture is an arrow. There's a notch in the nerve. When you have high pressure, you get concentric enlargement of the optic nerve head. If you have a vascular insult, you get a notch, and it's usually accompanied by a hemorrhage. So here's somebody, if you look on the right side here, who has both. They have probably a pressure defect infranasally, and they have a paracentral defect. So just because you have had pressure problems in the past doesn't mean you can't have overtreated hypertension now. Conversely, just because you have had a vascular insult doesn't mean you can't have high pressure. These tend to blend together. On the upper part of that visual field, it looks like they're separate. And as you look down below, you see superior nasal change, and you see a more dense infranasal change. So these things tend to blend together over time. So what are the vascular risk factors? Low blood pressure, vascular stenosis, low oxygen in the blood. If we look at low systemic blood pressure, it really came about because of overtreated systemic hypertension. The studies on blood pressure showed that the lower the systolic blood pressure dropped, better people did in terms of secondary cardiac and cerebral events. The problem is, when you do that, you lower the diastolic, and that's a problem. So when a patient comes in and says, my blood pressure is great, that's a concern. If they say it's good, that's fine. But when they say it's great, that worries me because it tells me it's probably a bit too low. These people get orthostatic hypotension. They get nocturnal hypotension, and that's when things are bad because that's when you're lying down and the imbalance between your eye pressure going up and your blood pressure dropping is a bad combination. You can do 24-hour blood pressure monitoring, or you can just have people check their blood pressure at night. Say, do you get up at night to go to the bathroom? And they say, most say yes. So before you even sit up, check your blood pressure. Have the cuff or have a wrist cuff in your bed, check it, write it down, because that'll give us the best idea of what's happening at night. So again, you can see because of this rich blood supply, if you cut that off, you're gonna make this optic nerve suffer. The arterial stenosis part of it, a lot of people have a history of coronary artery disease or cerebral vascular disease. This compounds the effect of the low blood pressure. So if you have low blood pressure, that's bad. If you have low blood pressure trying to push blood through a narrowed vessel, that's a bad combination. So you always have to think about this, especially in patients who have monocular glaucoma. Decreased blood oxygen is something we see a lot of at the VA, a lot of sleep apnea. So if you see people who have unexplained defects in their visual field, and they tend to be mid-arcuate, get a sleep study. Anemia is also enough to do it. Poor oxygen in the blood. So just end by saying, when you have people with glaucoma, remember the other risk factors: low systemic blood pressure, especially diastolic, arterial stenosis, get carotid studies, even though that only measures what's going on in your neck. But you may have to pursue it more with arteriograms. Faulty autoregulation is a risk. Think about sleep apnea, because the first thing that happens is sleep apnea, the endothelial cells get damaged. Ineffective cardiac function, get an EKG. Poor oxygen saturation, again, sleep apnea. Sleep position, sleep with their head above their heart. Tissue thickness, get a central corneal thickness. It tends to run in families also. And then cerebrospinal fluid is not a common thing, but there are conditions where that can happen. And glaucoma can also be associated with autoimmune conditions.
Thank you, Dr. Martone. It's a wonderful talk, and there are many things that we should be thinking about. All these factors play into each other. And so as our technicians are intaking the patients, working with the patients, doing patient education, reviewing medication lists, this will give them a lot to think about. Thank you for spending your afternoon or early evening with us. And I'd also like to thank all of our speakers today for their expert presentations, aiding us to deliver high quality care to our communities and to continue the tradition of excellence in eye care. Stay a few more minutes for the final door prizes, but before we get there, I'd like to take an opportunity to recognize Mark Langenheim of Photo Arts Printing Company in Torrington, Connecticut. He provided the expertise in development, production, and transmission of this program. Regeneron for their continued support of excellence in eye healthcare and as a major funding source of this program today. President Jim Martone of Connecticut and President Peter Menger for having the foresight and leadership to make this program happen. Of course, Deb Osborne of the Connecticut Society of Eye Physicians, our executive director, and Robin Pellegrino, the executive director for NISOS, who have the elegance, power, and the skill of coercion to make this production go live. We really could not have done it without the two of them, and we have another day of this to get through. Please remember to complete your CME evaluation forms. We'll put the website back up on the screen for all of you to see. But click on there. There was a question about the glaucoma questions, and keep scrolling down on the question page. They are there. We just checked on it. And this is the second page that you'll see on the website, and tap on the click here for CME certificates. And here's the last page where you fill in your name and email address. And that's good for 5.25 CME credits through iJacapo.